Afternoon all, welcome to Idea Ernad branch webinar series. Today our topic is Periodontal Surgical Consideration for Implant by Dr. Mayur Kaushik. Dr. Mayur Kaushik completed his BDS from Manipal College of Dental Science, Mangalore in the year 2001, and he completed his PG in Periodontics from Government Dental College, Nagpur in the year 2005. He has done various paper and poster presentations, ebook publications, and live surgical demonstrations. His area of interest in implants is much appreciable and has done various CD programs as a guest speaker. Currently working as professor and head in the Department of Periodontology at Subharti Dental College and Hospital UP, and also running his own clinic, Kaushik Dental Care. He is the mentor at Rochelle Implant Training Center and Lokpriya Super Speciality Hospital, Meerut. Over to Dr. Mayur Kaushik to start the webinar session. Thank you.
Thanks a lot, Dr. Shah. At the outset, I welcome all the participants and I would like to apologize straight away. Ever since Meerut has come in the red zone, there has been a lot of problems with regard to bandwidth at our end as such. So in between, I request all of you, in case Dr. Shah allows you to unmute your video audio as such, kindly let me know whenever I am not audible because in between that loss of connection might be there. So with this, I'll just uh, Dr. Sham, host has disabled attendee screen sharing that you'll have to enable once so that I can start with my screen sharing.
Okay, 1 second, sir.
Yeah, yeah, sure.
Sir, now?
Now it is there. Okay. So again, I just started the screen sharing once. Okay. And that unmute option for anybody, whoever is not able to hear, uh, can they unmute themselves as such, Dr. Sham?
Yes, yes, sir.
They can unmute. Okay, okay. Fine. Fine. So I welcome all the participants. I hope you had a heavy lunch as such. Okay. So post the lunch session, I was expecting something like this. I'm not sure how you are looking because I cannot see majority of you as such, but I would love to see because I like to interact in my lectures. Otherwise, it becomes very monotonous. I mean, this is one disadvantage of these webinars. It becomes a one-sided conversation, and many a times we are not aware whether the audience are able to hear us or not. So again, it is my humble request, Dr. Sham, let me know, please, whenever my voice cuts as such.
Yes, yes, doctor,
I
you are
bring to you
audible.
greetings from Subharti Dental College and Hospital. Okay, okay, thank you, Dr. Sham. And again, that request is I would like to see few of the attendees if possible, so that at least I can interact with few of them as such. Okay. I bring to you greetings from Subharti Dental College and Hospital, Meerut. This is the current college of occupation where I'm working. And our college is part of a huge university. For those of us who are not aware, it comes under the name of Swami Vivekanand Subharti University. And there are as many as 20 different colleges under this university. So we have, it is a huge campus. So if any one of you get an opportunity to visit UP, visit Meerut as such, please do visit. Our university is like a mini campus, a mini city as such. So somebody has raised the hand, Dr. Disha Nagpal. Okay. Am I audible as such?
Yes, sir.
Okay, they are raising the hand. That raising hand is basically that they
No,
I'm able to hear them. Okay, okay. Fine, fine. I thought some query was there. Okay, and I've been working in this university ever since I completed my post graduation in the year 2005 for the last 15 years from Government Dental College and Hospital Nagpur. And whatever I am today, it is because I had a wonderful, godlike person as my guide, Dr. R.K. Sir. It is Sir's blessings always, which I seek always in life. Now, this is the current department which I am heading in Subharti Dental College. This is the team of periodontists, our team at Subharti. Do come and visit the department sometime. I also have a clinic by the name of Kaushik's Dental Care where I practice with my father. My father is a general dentist, and this is the implant training center in which I am a mentor of. So, like, we are four mentors as such. Myself, then I have Dr. Rohit with me. So, Dr. Rohit is the director of Lokriya Super Speciality Hospital, and he's an endodontist himself. Roshal basically is short for Dr. Rohit and Dr. Shalya. Dr. Rohit being the director of Lokriya Super Speciality Hospital, and Dr. Shalya, his wife, she's also an endodontist, and she happens to be the CEO of Swami Vivekanand Swarthi University also. We are a team of four mentors as such. Dr. Prajesh, he's an oral surgeon, and Dr. Sumit Makkad, who is a prosthodontist. Okay? So let me know if my voice is breaking in between. I hope I'm audible. Am I audible, Dr. Sham?
Yes, sir, you are.
Fine, fine. And this is my small world. She is my wife, Dr. Nupur. She is a professor in the Department of Periodontics in Swarthi Dental College only. And she is my 9-year-old daughter, Adya. So, together, this was my short introduction. So, as dentists, as dental surgeon, we are supposed to be the smile architects of our patients. And as a dental surgeon, all of us know with regard to smile, it is not just about the white teeth, it is about the pink gingiva also. So, it is supposed to be a balance between pink and white, which actually determines whether we are able to deliver a patient a good smile or not. But when it comes to smile, naturally, missing tooth is something which a patient would be coming to us straight away. Patient comes to a dentist basically for two main reasons. Either it is pain or it is aesthetic. So missing tooth, the patient would be coming straight away. So what all options we had for a missing tooth? For a long, long time, we used to have these removable partial dentures. We used to call them as gum strippers, the weakest and the cheapest modality for removing or replacing a missing tooth. And then what happened was, for a long, long time, the success of our dental practice was actually determined by the number of FPDs we were delivering in a month, number of crowns we were delivering in a month. So this thing continued for a long, long time. And now is an era of implants. So with regard to implants, everybody wants to boast. Everybody wants to show off that I am placing so many number of implants in a month. And whoever is not practicing implants, straight away that person says that I need to practice implants because this is the in thing right now. But then with regard to implants, like this is the most mouth-watering sight to any dentist nowadays. An edentulous area, straight away we tend to think an implant. How to convince a patient for an implant? Because let us be very frank, with regard to dentistry in India, it is basically a price driven branch. People want to pay whenever they feel that an important or expensive material is being put in their mouth as such. Now, this is the thing which actually goes with regard to implants. Even the patients, thanks to the internet, are aware that implant is the most expensive dental treatment available as such. But with regard to implant, one thing which all of us have to remember is the prosthetic component, the crown part, comes much later. It is actually the implant which has to be placed surgically and which has to be accepted by biological hard and soft tissues, and then only once that acceptance, the success of the surgical component has come, then only the prosthetic component can be placed. So that is why the surgical component with regard to implants happens to be the base of implantology. So hence, worldwide, the accepted definition of implantology basically is it is prosthetic driven surgical treatment modality. So this is the first point which I would like to emphasize in this webinar. Implant is surgery first, prosthetics later on. And unless and until with regard to surgery, you are comfortable with three components, IRS, you won't be a good implant surgeon or a good dentist, in which I stands for a proper incision, R stands for proper reflection, and finally S stands for proper suturing. So unless and until, as a practicing dental surgeon, we are comfortable doing IRS. Do not touch implants. This is my basic, what do you say, take home message to all of you. kindly be comfortable with regard to IRS as such, okay? And otherwise, we end up getting situations like these. So, gone are the times when simply an osseointegrated implant, a firm implant was sufficient. Patients say aesthetics is very important. And always remember one thing, soft tissues happen to be the shield of bone. So, as long as we have strong soft tissues which are supporting the bone, no resorption would be there. But the moment soft tissues are not there, soft tissues are not healthy, your implant won't be having a very long life as such. So let us have a small discussion. Again, whenever I say discussion, actually, Dr. Sham, I love to interact with the audience here. I'm not able to see any audience, but not an issue. Okay, so with regard to all the participants, you were raising hands in between. Okay, please keep raising hands in between, and I can see I can allow to talk also. Okay, so all of you are raising hands. Fine. So let me know whenever I am audible, whenever you are able to hear me as such. So all of you are able to hear me. Great. So many hands I can see. So my presentation would be of two parts basically. The first part would be basics. Basics basically would mean that let us go through the points which we already know. Basics are the points which would be more relevant to beginners who have just entered the field of implantology. And then in the second half, I'll be taking up certain specific points which I feel as a pedontist, as a periodontal surgeon, which I can guide you as such. Okay. So whenever a patient comes like this, which is the first thing we are supposed to see, we straight away start thinking implants, implants. No. The first thing is whether space is present for placement of a tooth or not. So subsequently, the first thing which we are supposed to do is, we have seen that the mesiodistal distance is adequate. We ask the patient to bite as such. Okay? So in case interocclusal distance, also make sure that placement of a tooth is possible. Only and only then we go ahead with planning for implant. So what we do is next we advise an RVG, an X-ray, but that gives us a two-dimensional image. Subsequently, we advise a CBCT for a three-dimensional image. So a three-dimensional image gives us a 3D panoramic view. This is a beautiful view which we can use for motivating patients again and again. This particular PDF which your radiologist would be giving you, this goes a long way in motivating your patients, including it in the patient's education as such. And always, see, again, the problem with regard to CBCT is the patient tells us, Doc, you are charging so much for an implant and additional cost of CBCT. So that is when what you are supposed to do is you're supposed to show the patient the CBCT of an earlier patient, that this is the advantage of a CBCT, that even without raising your gums, I'll be able to see how much amount of bone is actually present for placement of an implant. So basically, this goes with regard to patient education. But the main view which is actually useful to us, basically, this is again a separate lecture on my in short, how to read a CBCT from a practitioner point of view. It basically tells us the width of the bone also and the exact length of the bone available. So based on that, we choose the size of our implant. So now what we do is, ideally speaking, again, surgically driven prosthetic treatment modality. So never ever forget the prosthesis part. So in the beginning few cases, ideally you would be needing something known as surgical stent or a prosthetic stent, even with regard to single tooth cases. Later on, with regard to single tooth, you won't be requiring. So this was how in the beginning, around more than 10 years back, we used to make the from a documentation point of view. But later on, the problem which we used to face with regard to this type of surgical stent was, the moment we used to place it at the time of surgery, we were completely blind, meaning at least I couldn't see where my lens still was actually hitting the bone as such. So ultimately, what happened was we did a smart thing. We started removing the buccal part of the surgical stent. So the advantage of this thing was, now whenever you were using it during surgery as such, you'll be able to see where your drill is actually hitting the bone. So this goes for the first take home point. Whenever you are using a surgical stent, always and always either transparent acrylic or at least the buccal part of the stent should be removed completely. That is the first point. So again, This is not of much use with regard to single tooth, but whenever you are placing multiple implants, trust me, no matter how expert we might be thinking we are as an implantologist, always and always going for surgical stent with regard to multiple teeth placement as such. Okay, so multiple teeth, first thing. Now, the next step is flap reflection. Now, when it comes to flap reflection, we feel uh, actually this is one of the most ignored steps. Okay, so what happens is straight away we think in terms of the implant kit we'll be investing in. I have so many implant kits. I have so many implant kits of this company, this company. Implantology has become more of a company driven branch rather than biologically driven branch nowadays. No, before you implant kit, you need to have a proper surgical armamentarium. And when I talk about basic surgical armamentarium, I'm talking about five classes of surgical instruments. Again, please keep raising your hands in between. Am I audible or am I speaking to myself? Dr. Sham, am I audible? Okay, you are raising your hands. Fine. Thanks a lot. Okay, thank you. Okay. So, first is the diagnostic set. Second is the incision and reflection set. Third is debridement instrument, suturing, and bone grafting instrument. So again, with regard to each of these types of instruments, majority of the instruments would be the instruments which you can buy from a local dealer also. Few have to be of a standard company. These are the instruments which will be lasting for a longer duration. So I'll be telling you specifically which instruments can be local and which one should be of a standard company. So with regard to the diagnostic set, one very important instrument which all of you should be buying before starting implantology is UNC 15 probe. University of North Carolina 15 probe. Now this probe you would be saying that sir, we already have a depth gauge in our implant kit. Why do we need a separate probe for marking, for making sure how deep we have gone in the osteotomy? No. The moment we use an land strip, your depth gauge won't be going as such. You need to go in for a UNC 15 Pro. Trust me, it becomes very, very easy. It has 5 millimeter markings at black markings at 5 millimeter intervals. Straight away, you get to know. Straight away, you get to know whether you are gone to that adequate depth or not. The second instrument is, of course, a tissue holding forceps. So, all of you are aware of the difference between a normal tweezer and a tissue holding forceps. Tissue holding forceps basically has a nail and a hole here. This is basically the moment you over compress the tissues. What will happen is ultimately this nail will be pinching on your thumb as such. It will tell you basically that now you are over compressing the tissue. So kindly relieve this thing a little bit. Now, with regard to reflection, always and always keep two periosteal elevators in your surgical set. A thin periosteal elevator, preferably of Euphrates, which goes for reflection. A thick or a broad periosteal elevator for retraction later on. So always and always just remember, trust me, I've seen ample and more dentists trying to raise a flap using a wax spatula. So all of you are aware of the difference between a wax spatula and a periosteal elevator. Raise the hand, at least one or two. Okay, fine, fine. So with regard to, okay, so many have raised, excellent. So with regard to the difference, we say basically in a wax spatula, the handle is not bulky because you're not supposed to apply pressure with a wax spatula on, and plus the end is not sharp. That is a wax spatula supposed to mold your wax with regard to fabrication of occlusal rims, etc. With regard to periosteal elevator, you always need to use a periosteal elevator, and this has to be of a good company. Finally, your BP handle, it has to be a number 3 BP handle, not a number 4 BP handle. Number 4 BP handle is used with prosthetic blades number 20 to 24, the ones which we used to do that border molding trimming when we used to make border molding in prosthetics as such. This is a number 3. It can be round or flat, but I generally prefer a round BP handle. So this is with regard to the incision and reflection instruments. Now we have debridement instruments. So debridement instruments, again, trust me, once we have raised the flap, even with regard to delayed implant cases, many a times tissue remnants which are there, they don't come out that easily. And suppose you have placed an implant and you wish to do bone grafting around the implant, all the remaining tissue tags have to be removed. For that, An excellent instrument is Universal Columbia 4R4L Curette of Ufridi. This is one of the basic instruments that you are supposed to keep in your set, because no matter how you feel that your flap reflection is very good, some tissue tags or something might remain. We are supposed that whenever you are trying to place an implant in an area, in a tooth, in which a large periapical pathology is there. Now, unless and until you were to debride that periapical pathology properly, and you were to go beyond the level of the periapical pathology, your implant won't be successful. And in case you wish your immediate implant cases to be successful, especially in cases with periapical pathology, always use a Lucas bone scoop. Lucas bone scoop is basically a surgical curate, again from Ufridi or some other company you can buy. Comes for around 7 to 8,000. It's like a large spoon excavator, but it lasts 2 to 3 years at least, depending on the number of cases. This is a beautiful curate, surgical curate, which you should be keeping in your set. Okay. Finally, we have bone graft carrier and bone graft condenser. Bone graft condenser also has one end, but generally you need another person to actually put that bone graft. A bone graft carrier syringe is a must. That is something, otherwise your particulate bone grafting would be a mess. So particulate bone grafting is one aspect which I'll be covering. As such, okay, bone caliper. Bone caliper is another instrument. Trust me, no matter how good your CBCT report might be, many a times error is there with regard to the dimension of the bone available. So your CBCT report was saying, let's say 7 millimeter, you raise the flap and you realize this is hardly 5 millimeter. No matter how much we feel that our eyes can measure with regard to millimeters, ultimately an instrument has to be there, chair side, by which you can measure the width of the bone and ultimately decide the size of your implant. Okay, so this is with regard to the surgical set, which all of you should be keeping before starting with this thing. A normal steel bowl, this is generally because the dappen dish many a times breaks if you are using wet autoclave for sterilization. So this is for placement of the bone graft as such. So now you have raised the flap. So again, with regard to reflection of the flap, especially in cases of delayed implant cases, do we have any choice? Do we have any choice with regard to the incision, type of incision? Is anybody aware? Dr. Shyam, can we unmute some attendant, some attendee also? No. Okay. Fine. Okay. Just raise your hand as such. Am I audible, Dr. Shyam?
Yes, sir.
Okay, fine. So with regard to the types of incision, okay. So majority of you are aware. So we have two basic types of incision which we can give. We have the mid-crestal incision and we have the subcrestal incision. As a periodontist and otherwise also, I always prefer the subcrestal incision with regard to delayed implant cases, because the line of incision doesn't line over your implant, and even your sutures won't be lying over your implant. Now, with regard to placement of this subcrestal incision, there is a doubt whether it should be on the buccal side or the lingual side. So, generally speaking, always remember the subcrestal incision should be such that it should always be facing the person or the person who is doing the surgery, the operator, not the assistant. Meaning, if I am a right-handed operator and I have to do surgery in the first and the fourth quadrant, the subcrestal incision has to be on the buccal side, so that once the flap is reflected, the entire flap as a pouch goes towards the assistant side. This has a lot of technical advantage at the time of performing of implant surgeries, because at the time of drilling also and at the time of placement of the implant also, retraction becomes very easy. And similarly, if you are doing or placing an implant in the second or the third quadrant, the subcrestal incision has to be on the lingual side. So just remember this thing with regard to the subcrestal incision. And again, remember with regard to subcrestal incision, the incision, reflection, and suturing takes more practice. So initially it will take more time, but then later on what will happen is basically your implant placement, the main part which you have to focus upon, will become much more easier. So always practice the subcrestal incision. So can you see in this case what I have done is, this thing was raised in the third quadrant, subcrestal incision given on the lingual side, just enough to see the entire ridge. And then the entire flap was raised and tucked into a pouch sort of a thing. So this has been tucked underneath, inside. So can you see how clean a field how easy the accessibility is with regard to subcrestal incision. So always remember, try to give subcrestal incision again and again. This is a blade which many of us don't use. Majority of us, many times as a practitioner, what we do is a normal 15 number blade, and we tend to do all surgeries with that 15 number blade. No, ideally for surgeries in the posterior area, for giving an incision in the posterior area, 12 number blade should be used. The reason for that is very simple. Basic rule of instrumentation is long axis of the blade has to be parallel to the long axis of the tooth which you are instrumenting. Now with a 11 or for that matter a 15 number blade, this blade placement is not possible parallel in the long region. It has to be bent at an angle. So this is where it becomes a mess. We are violating the basic rules of instrumentation in case we are giving this thing using a 11 or a 15 number blade in the posterior area. Are you getting a point? Always and always in a posterior area, we need to use a 12 number blade for giving an incision. And as you can see, at least the terminal part of the blade is parallel to the long axis of the tooth being instrumented. Okay. So one or two of you students, whenever you like some point which I'm telling, which you might not have heard earlier, or you this thing, please raise your hand. Okay, few of you are already raising a hand. Thanks a lot. Thank you, because ultimately it is completely the sound from the other side is not there, so I become confused. Okay, so once you have raised a flag, thanks a lot. The next part is we are supposed to start with the osteotomy preparation. So again, this is the basic. Osteotomy preparation has to be done in an atraumatic manner. Okay, we say respect the bone and the soft tissues, and the bone and the soft tissues will be respecting your implant. So basically, the drilling has to be done. The osteotomy preparation has to be done in such a manner that no heat basically at 800 to 1200 RPM. Now this is where the problem starts. Okay, such low RPM is not possible in the case of a rotor. The RPM is in lakhs as such. It is not possible in the case of micromotor because the required torque, which is required for rotating the instrument. Dr. Sham, am I audible?
Yes, sir.
Okay, the voice is not breaking, right? Or is it breaking?
Yeah, it's somewhere, but okay, sir.
Okay, okay. है ना? Please let me know. है ना? Please let me know. I'm refreshing my connection again and again. Okay.
Yes, sir.
Try to speak a little slow, but please let me know. है ना? Again, one or two
Sir,
attendees,
while
if I am able
moving
to see,
only
that would
it's
be fine.
breaking, sir.
Otherwise, while moving, it is breaking.
Yes, sir.
Okay, so I'll try to sit still then.
Both
Okay.
your video and audio
Fine,
is
fine.
breaking.
Thanks a lot. Okay. And now, am I audible, Dr. Sham?
Yes, sir, you are.
Audible. Okay, fine. So with regard to this RPM, which is there, with micromotor, we cannot generate this RPM. It will simply get stuck in bone. It is almost similar to we trying to, let's say, and would it be easier if I were to switch off my video? Will that make it better? No.
No,
Okay, fine.
sir, it's okay.
It's thanks a lot. Okay. So basically, the problem with micromotor is if you were to try to use a micromotor at 800 to 1200 RPM for making an osteotomy, what will happen is it will get stuck in bone. It is almost similar to you trying to make a cavity, a class 2 cavity during your BDS time, and the air pressure was less. How many of you have faced this thing? That air pressure was less whenever we were trying to make a this thing. Okay, ample of you have faced. It would be almost similar to that. Okay, so at least I'm audible. Fine. So basically, what happens is that is the thing which is taken care of in a physio dispenser. Physio dispenser basically you can buy, which I have been using for the last 10 years now, NSK, Surgic AP, and then we have the most expensive one, WNH. So basically, I'm sorry, the most expensive one, which basically is not available everywhere, the Ben Air one, AMU has it, it is around 3.5 lakhs. No matter which physio dispenser you are investing in, basically what you are paying for is this. Okay, basically you are paying for something known as gear reduction. A gear reduction handpiece, which separately costs 25,000, comes with the physio dispenser. And the meaning of this gear reduction, 20:1, basically means for every 20 rotations in the motor, the burr or the drill rotates only once. So that is the meaning of gear reduction. The torque is amplified 20 times. Are you getting a point? So basically, just remember, with regard to physio dispenser, you are basically paying for the gear reduction to amplify the torque. So always and always invest in a good physio dispenser. Okay? Next comes the implant kit. Again, broadly going through the components, the most important components are osteotomy, 2,500 to 4,500. The osteotomy has to be prepared in a graded manner. We say sequential drilling has to be done. One of the worst things, one of the worst experiences which you can have as a budding implantologist, as an implantologist who has just now started placing implants, is to use the round burr. Because trust me, the round burr tends to slip a lot at low speed. So never ever use a round burr for beginning of your osteotomy. Okay? You can use a large round burr basically for trimming of the sharp edges of the of a ridge as such, but never ever start with a round burr. Okay? The instrument which you are supposed to use, which you are supposed to become comfortable,
Hello?
and which is the cheapest
Oh,
drill,
hello.
which are the
Hello.
cheapest drills. You are saying something, Dr. Sham?
Arunavale. Yes.
Dr. Sham, I
Yes.
can hear you. Okay, okay. Fine, fine. Not an issue. I thought something was there. Fine. So, is the lance drill. Now, lance drill starts from just 1700 rupees onwards. So, always and always invest in a good lance drill. So, majority of you, and again, it is lance drill, not lancet drill. Many of the people straight away say it is lancet drill. So, have you heard of lancet drill earlier? Okay, all of you have heard. Fine, majority have heard. So the next is always keep a set of short drills with you. Okay, placing in implants many a times with regard from an accessibility point of view in full mouth rehab cases is easier because the antagonizing teeth are not there from an accessibility point of view. What do I mean from an accessibility point of view? I'm able to place my burr straight. I'm able to place my drill straight, my handpiece straight. Are you getting a point? So whenever you are trying to place an implant, let's say with regard to 3747 areas in a tooth, in a mouth in which antagonist is present, that is where you require short drill. So this is something which I realized at my third implant case itself. Ultimately, what was happening was my drill was either like this, and I was making a hard time. I was having a hard time trying to keep it straight, and I was asking the patient try to open the mouth wide. And ultimately, the patient was asking me, "Doc, are you planning to sit in my mouth or what? I cannot open it wider than this." So ultimately, I realized short drills have to be part and parcel of your kit as such. Okay, so this is one thing. Now, there are many sets available, many kits available which have a drill stopper. Okay, so drill stopper basically means you don't have to remember the 6, 8, 10, 11.5, 13, and 16. It will be stopping at that particular point. So, are these kits less expensive or more expensive? Raise your hands. How many of you are saying less expensive? Good, nobody. How many of you are saying more expensive? Excellent. Okay, so basically, your kit price is determined on the number of drills. Now, suppose for a particular length of implants, 10 millimeter implants, we have one set of drills. 11.5, we have another set of drills. Naturally, what is happening is the overall cost of the kit is increasing. And implantology is all about investment and return. Trust me, in India, it is not that easy to get returns. Right now, all practices are more or less shut up. So we used to have drills like this also. These were drills with internal irrigation, meaning what they used to say was that once you have started drilling, the irrigant is actually reaching the top surfaces of your osteotomy. It is not going into the base of the osteotomy. So with these internal irrigation drills, what used to happen was that ultimately the irrigating solution used to reach the bottom of the osteotomy site also. But there was a problem. These drills were almost impossible to clean. Lot of bone debris used to get accumulated, and ultimately, what happened was over a period of time, it was found out that these drills were gradually more or less withdrawn from the market. So, majority of the drills are not having internal irrigation, meaning they're not hollow from inside. Again, you must have heard of the term pilot drill in your textbooks. So, majority of the textbooks used to say start with the pilot drill. A pilot drill used to be a drill in which 2 millimeter in the beginning used to be non-cutting and the remaining part of the drill used to be of the cutting type. So basically, this pilot drill is not there in majority of the implant kits right now. What we use is the 2 millimeter twist drill straight away, and we tend to call it as the pilot drill. No, that is not a pilot drill. This is a pilot drill. Okay, so always remember that the osteotomy has to be done in gradual increments. Atraumatic osteotomy has to be there. Now, this color coding also reminds you of something, right? All of you have your RC files. So color coding with regard to RC files, it follows generally the same pattern, same color coding as such. And finally, once your osteotomy is prepared, what we have to keep in mind in general, no matter what system we are using, we have to keep in mind that no matter how atraumatically we have done. Okay, so my voice was cutting, right? Fine. Is it coming now? Is it coming now? Voice is coming.
Sir, now the voice
Is
is
it coming now?
good.
Okay.
Ah, yes, now it's fine.
Now it is fine. Okay, fine. Thanks a lot, and sorry for this thing straight away, but still I'll try to go a little slower. So basically, the osteotomy has to be smaller than the diameter of the implant to be placed, slightly smaller. Many a times they say 0.5 millimeter lesser in the mandible, 1 millimeter lesser in the maxilla. Many implant companies say it should be almost of the same size as such. I don't recommend that thing because ultimately what happens is the body takes that osteotomy as an insult. So some amount of resorption, bone resorption will be occurring later on. So that is what we are supposed to keep in mind, compensate for that resorption later on. Initial implant stability, primary stability is because of the osteotomy being lesser. So now this part is fine. So now we are ready to take out your implant. We say implant has something known as implant mount. Implant mount is just used for carrying the implant in the patient's mouth, and then ultimately for placing the implant, we tend to use the most, and that is basically a torque ratchet. So this torque ratchet is something which rotates in both the directions. Meaning, if we have to replace the tire of our punctured tire of our car, we'll be rotating it like this, taking it out, then rotating it like this. That is a wrench. Ratchet, on the other hand, rotates in only one direction, meaning you are tightening it like this. Once you're moving it in the reverse direction, it won't be getting loosened. It can rotate in only one direction. That is the meaning of the word ratchet. Okay. Now, ratchet is of two types. My favorite type is, of course, the friction type as such, or the toggle type. And we have few companies who are basically given the beam type or the spring type also. So that depends on a personal choice. I personally am more comfortable with the friction type. You might be more comfortable with the spring type, but that doesn't mean that one is better than the rest or something. It basically depends more on operator convenience and operator choice as such. Okay, so once we have implant motor driven implant placement also, and this is not something which I recommend in the beginning, and we have that initially placement can be done by the hand, and then finally with the torque ratchet it can be tightened. Okay, so finally implant is placed. We ideally should not place it, tighten it beyond 30 NCM torque, Newton centimeter torque, because then a lot of compression necrosis occurs in the surrounding. And then finally a cover screw is placed, and my voice is breaking again and again. So is it coming now? It is coming. Okay, so just give me a moment. I'll try changing the connection if possible. So because all of you have told it ample number of times now, so let me know, just okay, just uh, because this is a problem which we are facing. So I'm Dr. Shyam.
Yes,
Is
sir.
it fine that just for a moment I try to use a different connection if possible?
Yeah, you can. No
Okay, let
problem.
me know if this is better.
Okay.
You know,
Currently, you are
because
using the new one, right? Hello. Hello, sir. Hello.
Can you hear me? Can you hear me?
Yes, sir. Now it's
And
fine.
now it is better. Fine, fine, fine. I've just changed the connection as such, and I'll just start with the screen share again. So, hmm, where was I? So again, is my screen visible, Dr. Sham?
Yes, sir.
Fine, fine. Thanks a lot. Okay, so now we have placed an implant and we have sutured it up properly. Okay, so can we place a crown straight away? No. This is the first thing we are supposed to remember, that ideally, once you have placed an implant in a bone, this is how your implant looks like. So the initial stability of an implant, the tightness which was there of that implant which you have placed, is basically only and only because of this 2 millimeter of cortical bone. So this 2 millimeter of cortical bone is very dense, very strong. But the problem is the strength of this cortical bone comes at the cost of its vascularity. So basically, even though it is very strong, it tends to resorb at a very fast rate in response to trauma. So initially, the tightness of your implant, the thing which we call as primary stability, is only because of this 2 millimeter of bone. So this primary stability tends to reduce with time. This cortical bone, what will happen is this medullary bone will grow into the threads of the implant. This is the thing which is called as secondary stability, but we are more aware of the popular term for this thing, and that is osseointegration. So osseointegration or secondary stability is something which goes up over a period of time. So always and always remember this graph. At the end of 21 days, what happens is the implant is in its weakest state. The patient is starting telling you, Doc, now the sutures have been removed. Can I start eating from this side? Can I load the implant immediately? The immediate loading is very popular nowadays. No. As long as you are using a normal, non-biomodified implant, biomodification I'll be covering up in the last, there is something known as bone healing. We are clinicians, we are not God. Again, please raise your hand wherever the voice breaks in between. Okay. So we cannot accelerate this wound healing to a very large extent. So this osseointegration, secondary stability takes time. We are supposed to give the body that time, many a times 3 months in mandible, 5 months in maxilla, 6 to 7 months in case you have placed an additional bone graft, etc. Okay, but give it time. Okay, so this is one thing which has been proven over a period of time. So always and always, what has happened is people realize that ultimately this secondary stability is more dependent on surface area of an implant. If surface area of an implant is more, this secondary stability, more area for bone to grow into, more stable will be your implant. So this, for increasing the surface area, what they did was two changes were there: macro surface designs and micro surface design. With regard to macro surface design, basically this is the broad thing which you should be knowing. We have two types of thread design based on the macro surface: active thread design and passive thread design. Active thread design basically means that the threads are further apart and they are deeper. The thread depth is more. So while placing, the implant or itself plays a role in the drilling process. So these are much more easier to place, but ideally speaking, initial training of implant should be on passive implant, because these implants tend to take their own course. As long as you don't know how to direct the implant properly, what happens is, especially in maxilla where the bone is not very dense, etc., what happens is it tends to take its own course. So in the beginning, don't go in for this thing. Later on, this will become your favorites. Okay, especially in cases of immediate implant cases. You have extracted a tooth and you wish to place an implant immediately. Active implant design is better. Okay, the advantage of passive implant design is the BIC, bone implant contact, is more in the case of passive implant design. So all of you must be knowing examples as such. For example, Toreg OS, Toreg S add-in, or Alpha Bio SPI is basically active. We have Alpha Bio DFI, which is passive. Majority of the Korean implants are passive in design. So it is a personal choice, but I would recommend in the beginning use passive design. Then if you feel that you are comfortable, you can move on to active design. This is the only thing with regard to macro design modification that you are supposed to remember. Even in the radiograph straight away you'll be able to make out this is basically active implant and this is basically passive implant. All of you are able to make out this thing, active and passive as such. Uh, can I see hands as such? Active and passive. Did you understand a little, Dr. Sham? Am I audible?
Yes, sir.
Okay, okay. So, can I see any hands? Did you understand or you want me to repeat any of the attendees? Okay. Did you understand? Active and passive. Active was deeper threads and passive were threads which were not so deep. Is it fine? I can't see a single hand. In the chat or something, can you say something? Is any attendant here as such, Dr. Shyam?
Sir, we got two texts in this chat. Yes, sir. Yes, sir. Yes, please repeat
Okay,
once.
please repeat once. Okay, okay,
Understood,
fine. So,
sir. Like that.
understood, sir. Fine, fine, fine. So, with regard to active and passive, active is thread design. Threads are deeper and further apart. That is active. Passive are threads are not so deep and they are closer together. Thread pitch is less. That is passive thread design. Okay. Again, both the implants play a role with regard to implant placement. Placement of an active implant requires less force. It tends to go in easily. With regard to passive, more force is required, but control is better, especially for the beginners with regard to passive. So just remember, initially go in for passive. Later on, especially in cases of immediate implants, please go in for active. So chats are coming. So yes, sir. Okay, so fine. The second modification which they did to increase the surface area was at the microscopic point of view. So microscopic point of view. So microscopic made, but on the whole, the surface was made even more rougher. So in order to increase the roughness, during my PG time, 2002 to 2005, lot of emphasis was there on additive implant surfaces. This term was very, very popular. TPS, titanium plasma sprayed. So have you heard of titanium plasma sprayed? Okay, so you have understood. Titanium plasma sprayed. Have you heard of titanium plasma sprayed? Okay, fine. So hand part has stopped. Titanium plasma sprayed basically meant that on a screw, they used to spray titanium in plasma form. Plasma basically is a state between solid and liquid. So once this sort of highly liquid titanium used to get attacked onto the titanium surfaces of the implant, globules used to get attached on the implant surface. We used to have globules which were attached on the outside. So this was the thing which was very popular earlier to increase the microsurface design. But the problem of these additive processes was that ultimately what used to happen was that the osteotomy site had to be smaller than the diameter of the implant. So once we used to put the implant inside that osteotomy, these globules on the implant surface, which were attached on the outside, used to get removed from the implant surface. So ultimately, all the coating of implant used to be lost. So nowadays, hardly any implants will come across which have additive implant surfaces. Nowadays, the surfaces which are used are SLA, sandblasted large grit acid etch, meaning instead of trying to add something to the surface, they bombard it with alumina particles. So now what is happening is on the implant surface, instead of globules being added, ultimately we have depressions present. So these depressions and finally acid is put, the depressions are increased as such. So basically what happens is now is the era of subtractive implant surfaces rather than additive implant surfaces. So now these surfaces are the ones which are basically used. Given a choice with regard to BIC, you would be saying whether to go in for a longer implant rather than a wider implant. So can anybody raise the hand? How many of you would prefer a longer implant? Uh, can you raise your hand? Or in the chat somewhere, uh, in the chat, longer implant. Okay. And how many would prefer shorter implant? Is my voice coming now, Dr. Sham, or is it again breaking in between?
No, no, sir. Now it's better.
Now it is that. So I got a response, uh, wider implant. Very good, very good. So always and always remember, given a choice, always go in for a wider implant as compared to a longer implant. Given a choice, both can be put, but 1 millimeter increase in the diameter, that is the width of the implant, increases the BIC, bone implant contact, by as much as 30%. On the other hand, 3 millimeter increase in the length increases the BIC by only 10 to 20%, depending on the type of implant. So always and always remember, given a choice, go in for a wider implant, even if you have to place a shorter implant. So this is one thing. So once you have placed the implant, you have waited for, let's say, 3 to 5 months. Then you go ahead with the second stage surgery. So in this case, now I've waited. Second stage surgery, you give an incision, and once you have given an incision, you tend to raise the flap. So when you are raising the flap, this is again one thing which I always emphasize. Okay, never ever go in for shortcuts, all those punch, etc. Can you repeat the reason? Okay. Reason with regard to width for using shorter implant. No. Again, uh, I said I don't say use shorter implants. No. BIC depends on both the variables. BIC depends both on length as well as breadth, that is width. Okay. What I said was that suppose we don't have ample length available, but we have a choice of placing a wider implant. That wider implant will compensate for that increased length better. I didn't say place a shorter implant. No, I am not in favor of shorter implant, because majority of my failures have been with regard to 8 millimeter implants, and personally I don't recommend less than 8 millimeter implants as such. But suppose the entire length, let's say from the crest till the mental foramen, let's say is 10 millimeter, you say from a safety point of view, I would prefer placing an 8 millimeter implant. Never ever place 3.75 into 8 millimeter. It should be at least 4.2 into 8, or preferably 5 by 8 millimeter. Did you understand? The query in the chat, it was there. Okay. I'm not saying go in for short implants. No. What I am saying is that given a choice, in case you don't have the length available, try to increase the width. That will more than compensate. That will more than compensate for the reduction in the length. But given a choice, go in for both length as well as width. Are you getting my points? That was the only emphasis. Okay. So this was with regard to short implant. So second stage surgery, again, always and always try to do it for by the conventional method. In case you feel that ample tissues are available, never ever sacrifice the gingival tissues. We give an incision, raise the flap, we remove the cover screw. Once we have removed the cover screw, we have the implant collar available, in which we place the gingival former in the crest module of the implant. And once we have placed the gingival former, we suture it up. And can you appreciate the amount of pull which is there of the soft tissues around the gingival former? The amount of pull basically is the thing which won't be there. It won't be there in case we use those tissue punches. Okay, so this is again which I would like to emphasize. Okay, as an implant surgeon, we have to be comfortable with IRS. Okay, we cannot look for shortcuts. I have this special tissue punch available by which I'll expose the implant directly. No, that is not acceptable. What we should be doing is basically that we should be using our normal IRS only. So once we have done this thing, the next thing is we have a beautiful implant collar which is made at the end of 15 to 21 days. So basically, implant surgery involves 4 steps. We have first stage surgery, we have second stage surgery, we have third impression taking, and finally crown delivery. The first two are purely surgical steps. The next two are purely prosthetic steps. So let us just superficially go through the prosthetic part also, very superficially. Okay. So with regard to impression taking, I always and always recommend the implant level impression only, not the abutment level impression. Abutment level basically means that what we are doing is we are placing an abutment, we are doing crown cutting just like the way we do for a normal PFM crown, and we take an impression. I never recommend that, because ideally The beauty of an implant prosthesis is it should appear as if it is emerging out of the soft tissues. Are you getting a point? Okay. So with regard to implant impressions, always and always it should be implant level impression. That is the thing which you are supposed to remember. Now in implant level impression, we have two types of impression techniques. We have closed tray and we have open tray. So first I'll demonstrate the closed tray in one of my patients. So closed tray basically means that either you are taking it for a single implant or you are taking it for multiple implants, but the implants have been placed parallel to each other. In this closed tray, we tend to use a transfer coping. Transfer coping is the component which actually transfers the actual angulation of the implant from the patient's mouth into the cast. So the transfer coping is actually smaller. It doesn't come out of the tray as such. That is, once you have tightened the transfer coping onto this is known as transfer coping, we tend to take an X-ray to see whether the transfer coping is properly fitting or not, and then we take an impression in the patient's mouth. So are you able to see this tray? Nothing is coming out of this tray. This is a stock tray which is used in closed tray impression technique. Okay. So once I remove this impression tray, once I have removed this impression tray from the patient mouth, I can straight away see these are the depressions present. Okay. Now what I do is I have to remove this transfer coping from the patient's mouth. I remove it and now I combine it with another component known as implant analog. I combine it, I screw it outside the patient's mouth and then I reverse it. This part, transfer coping, goes into the depressions in the impression. So now my impression is complete. I can send it to the lab. This is implant level closed tray impression technique. Okay. Suppose you have placed multiple implants, but you haven't been able to place the implants parallel to each other. Let's say some anatomical structure was coming somewhere, or maybe what happened was bone was lesser. You had to place it at an angle. In such cases, non-parallel implants or multiple implants, basically we go in for open tray impression technique. Open tray impression technique basically means that the transfer coping is basically long. It actually juts out through the tray which you are going to use. In this case, we tend to use a plastic tray. We mark on that plastic tray where our transfer copings are touching as such, and we tend to make holes in the tray. So are you able to see? I've just trimmed off where those marking was there. And then subsequently what has been done is, once I have taken the impression, the screw at least of the transfer coping is jutting out of the tray as such. Now what I am supposed to do is, I am supposed to use my hex driver. I am supposed to remove the screw. And once I remove the tray, the transfer copings actually are picked up along with the tray itself. So this is known as pickup impression also. Okay. And now outside the patient's mouth, I tend to tighten up the implant analogs onto those transfer copings. Now again, these are basic things which you will have to do in your clinic. YouTube has videos also, but these are things which you have to do on your own. Are you getting a point? So this is one thing which you have to remember as such. And then finally, you can go in either for a cement retained or a screw retained prosthesis. And that depends on basically what you're giving to your lab. In case you are giving a normal titanium abutment, you will be going in for cement retained. In case you are giving a plastic abutment or a plastic sleeve, you will be going in for screw retained. As a periodontist, I always recommend screw retained prosthesis rather than cement retained, especially in the posterior area, because the chances of peri-implantitis are very, very less with screw retained because no cement would be jutting into the underlying areas as such. So always and always remember this thing. So again, chat is completely empty. Did you understand a little bit? Many a times the prosthetic part is a little bit more difficult to understand, and I don't know why I have stopped seeing the hands. Okay, so you understood. Uh, okay, a few of you have understood. Good, good. Okay, nice, nice. That is what I was thinking that maybe people have started leaving. I'm sorry for the connection as such, but the point remains the same. Okay, this is basically, these are all my clinic snaps only, for which at least we try that a basic idea we should be getting. Okay, so this was our maintenance to retain. And then finally, because of such complex steps, of surgery, prosthetics, Dental Council of India basically said that three branches are supposed to work hand in glove with each other. oral surgery, prostho, and perio. So, how many of you feel that these three branches work hand in glove with each other? Just write yes or no, sir, in the comments. Yes, sir, or no, sir? Do they work? Yes. Okay, very good. How many of you say no? No, sir. Very good. No. One no. Then more should see. Personally, I don't think so. I don't think so. They work in hand in glove with each other. Basically, what happens is because of two main reasons. What further have come? No, sir. Okay, fine. Now everybody is no, sir. Okay. So basically, what happens is because of two main reasons. Firstly, status symbol. Secondly, money involved. What was supposed to be a hand in glove partnership between the three specialties became something like a tug of war. Ultimately, everybody started saying, this is my specialty. This is my specialty. A prosthodontist started saying, patient has come for replacement of a tooth. This comes under my specialty. Oral surgeon started saying that I am the big surgeon. I can place implants anywhere. This comes under my specialty. And somewhere a poor periodontist saying, I also know how to do flap surgeries. I know basic prosthetics. This comes under my specialty also. So because of these stupid specialists in few of these three specialties, ultimately what happened was it became like a story which we used to hear when we were a small children. Two cats, in this case, three cats fighting over a piece of bread and a monkey coming in between, and that monkey saying that I'll help you in dividing. This part is smaller, this is bigger, I'll take a bite of this. And ultimately what happened was the monkey took the entire this thing. So what I mean to say is that by the time such stupid specialists are fighting with each other, a general dentist actually filed an RTI in the Dental Council of India, to which on 6th May 2016, DCI reported with this. So DCI gave it in writing that a person possessing recognized BDS degree can practice dental implantology, and DCI does not recognize any graduate or postgraduate degree in dental implantology. So this is the current guideline which still holds from DCI. So this actually, okay, about the plastic abutment, sir. This I'll explain with more photograph. Plastic abutment basically means, Hashit, that ultimately the abutment is completely melted in the process, and the crown and abutment are in a single process. So this I'll have to explain separately as such. Okay. So I'm sorry for this thing because I need more photographs with regard to this thing. Okay. So I'll explain it. I'll but as of now, ultimately this comes, implantology comes under general dentistry with specialists helping. So ultimately, let us cover a few more periodontal considerations of this thing. Now, when it comes to perio, everybody has a very skeptical role with regard to this thing. Okay, so one more thing in the chat. Okay, plastic abutment I'll take up again. Okay, that is few slides back. Later on I'll take. So ultimately, few people are very skeptical about periodontists placing implants. What they say is, aren't a periodontist supposed to save a tooth at all possible costs? No, that thing is completely changed. According to an article by Cloakworld and Newman, these people are actually the authors in the current edition of Carenza, our standard textbook. What they have said is that periodontology has changed because of implants more than any other specialty. There has been a paradigm shift towards saving tooth at all costs, towards extraction of maintainable teeth to improve aesthetics, function, and long-term success of dental restoration. So ultimately, now it is given by the authors of Carenza itself that in case you feel the prognosis is not good from a periodontal point of view or from a general mastication point of view, don't go in for trying to save the tooth at all costs. Always and always extract the tooth so that the implant should have better prosthesis. So always remember this thing. Nobody, none of you. How many of you are periodontists here in this thing? Periodontists would be periodontists. Any periodontist here? Uh, can you just write in the chat once? The arm raising has held, stopped actually. So ultimately, I'm not able to see the arms as such. So few periodontists, yes, sir. Okay, few of you are there. Excellent. Can maintain a good implant of surroundings. Excellent. So very good comment, Shikhar. Okay. Periodontist. Okay, lot of periodontists to be. So ultimately, just remember, our Carenza itself states that we should be placing implant. But talking about implants is like trying to cover up the tip of the iceberg. By the time you actually reach the topic, half of the participants have a lot of doubts which cannot be cleared in a webinar as such, but still I'll try to cover a few important points. So these are the 5 points which in short I'll be covering up. Okay, I'll be mainly discussing it from a patient point of view. Okay, so that at least it doesn't become too toxic. And then again, in your chats, please let me know wherever I am not audible. So the first important thing is guided bone regeneration. So all of us know GTR, guided tissue regeneration. No, guided bone regeneration basically means that let us say we talk with regard to immediate implantation. You are placing an implant and you feel this implant on its own will not survive. You need bone graft around this implant for this implant to survive. For example, have a look at this case. Can you see? Uh, this patient came to my clinic. The bridge was broken. The central incisors were broken. The bridge was broken, and only the root stumps were remaining. And especially with regard to one root stump, we had a large periapical pathology. So first and foremost, can implant be placed in this scenario or not? How many of you say yes, sir? No, sir. Can we place yes or no in the chat? Anybody? Yes, sir. Excellent. So lot of this thing. Yes, we can place an implant in this scenario because there is ample and more bone available over the periapical pathology. So this is the first thing which you have to remember. Okay. But in order to excavate this periapical pathology, we need a very special instrument. What's the name of that instrument? Which was the instrument which we had taken up? Do you remember? Lucas, excellent, Gajanan, Dr. Gajanan. Lucas bone scoop, excellent. So now the full form name has also come, excellent. Okay. So Lucas bone scoop. So what I did was I removed the root stumps. I curated this periapical pathology properly, and then finally what I did was I placed two implants. So now with regard to these two implants, can you see? Okay, so Lucas bone scoop, good. Socket is like this. My implant is like this. Okay? There's ample and more space remaining around the implant. Unless and until I place a bone graft around this implant, my implant will fail. Okay. Not only around the implant in the socket, I need to place bone graft in this huge window which has formed because of the periapical pathology. So ultimately what I did was I did bone grafting. This is FDBA bone graft from Tata Memorial. Now, this graft would be retained on its own. In order to retain this bone graft, otherwise it will come to flow out, I need to place a membrane also. This membrane this I use periocol, collagen membrane, basically. So this membrane basically helps to retain the bone graft. The combined use of bone graft as well as membrane around implants or with regard to just regeneration of bone is known as guided bone regeneration. Okay, we are using bone graft preferably with the membrane to regenerate only and only bone. This is different from GTR. And most important thing after this is primary closure. Trust me, without primary closure, everything is a waste. You have placed three foreign bodies inside. You have placed implant, you have placed bone graft, and you have placed a membrane. Unless and until you were to close it properly, the entire thing is a waste, complete waste. Okay, so primary closure is a must, but then again, you cannot send the patient just like this. If you send the patient just like this, what will happen is sir, which one is better? I'll be coming to that. DFDBA is better, but clinically FDBA also good results are there. Okay, so this or maybe I'll be addressing these later on also, but later on also. Okay, now I cannot send the patient like this. Patient was 81-year-old lady, but the first thing which she told me was, Doc, I won't be able to attend my kitty parties. So ultimately, you cannot load it right now, but we give something known as Maryland prosthesis. Maryland basically means it has wings which take support from the adjacent teeth. And I left it. I left these implants for a period of just 4.5 months. And in 4.5 months, ultimately, once I went ahead with the second stage surgery, incision, and I raised the flap. Are you able to see? Meaning this is one of the best sites. Not exactly the best, but still a very good site as such. I had a hard time visualizing this implant. I couldn't visualize this after a lot of scooping with my bone curate and all. I was able to see. But ultimately, what I had to do was I had to pick up an erotor and a round burr, round carbide burr, and I had to expose the implant. So this much was the amount of regeneration. Question answer to ask your doubts after the session. Okay, okay, Dr. Shyam, thanks a lot. Thank you. But they can keep on responding as such. Okay. So this is the maximum success. This is considered to be a success in implantology in the sense that my implants not only survived, actually bone growth occurred on top of the implant in a case in which a large periapical pathology was there to begin with. Are you getting a point? So this can be achieved only and only by using good materials, biologically good materials, not company-wise good materials, and good surgical skills. Primary closure is the key. Bone grafting, you require majority of the cases in which you will be extracting root stems of multi-rooted teeth. So with regard to multi-rooted teeth, you would end up cases like this. Periapical pathology is there. RC treatment was done earlier. Now, whenever you are extracting root stems of RC treated teeth, what happens is they don't come out that easily. Trust me. No matter how much atraumatic extraction we are trying to do using our luxators, ultimately some amount of the bony wall goes. So what happens is once the root stems I had extracted, and this was how I had ultimately sacrificed this bone as such, and ultimately after placing the implants, you cannot leave it like this. You need to place bone graft around the implant, and most important thing is primary closure. Now, in this case, membrane was not used. This is again one thing which I would like to emphasize. Membrane placement is not a must. In case you feel that the bone graft will be retained sufficiently by the socket itself, no need to place a membrane. By membrane placement, you'll be enlarging the wound size, more difficult to approximate. This area is the area of mental foramen. I cannot even give a vertical incision. Otherwise, chances of paresthesia, etc. will increase. Okay. So, but the important thing is primary closure. So, membrane placement in GBR, wherever you feel retention of the bone graft would be an issue, do not keep this thing in mind that basically that bone graft coming in contact with the flap would be an issue as such. Okay, so this is one thing which you remember. Another case, I don't have the clinical snaps. So patient came for removal of these teeth and placement of implants in a bridge later on, but the problem was implant placement, ample bone was present, but we had a pathology here. So ultimately, simply removal and placement of implants was not sufficient. I had to do bone grafting here. Okay, so this is one thing which has to be there. So dental bone grafting is something which all of us are supposed to be aware of. Many periodontists are there, and I have a query. I'll just see in case it is. What sutures? Excellent, excellent point. The sutures which I have used are one of my favorite sutures. This sutures you are talking about, right? This is undyed vicryl. Undyed vicryl. Remember vicryl PGA PLA suture? So dyed vicryl is violet in color. Now that violet color suture actually resolves very slowly. It takes around 30 days or so. This is undyed vicryl. This is my favorite suture which I use. And undyed vicryl suture generally resolves in 15 to 20 days. And the color match is also very good. So I generally prefer undyed vicryl anytime over silk. This is monofilament, hardly any this thing is there. Okay, hardly any wicking effect is there. Okay, so undyed vicryl, excellent. You can ask questions in between as long as I don't have to elaborate much. Okay, now with regard to dental bone grafting, the first thing which you are supposed to keep in mind, the first thing which you are, thank you, sir, for having. Okay, thank you, most welcome. Okay. So the first thing which you are supposed to keep in mind is size of the bone graft. Okay, before we move on to which type of bone graft, the first thing which is very important, which size are you planning to use? So we have large particulate bone grafts and we have small particulate bone grafts. I'm talking about particulate bone grafts only. As a periodontal surgeon, I do only particulate bone grafting. Block bone grafting, my oral surgeon colleague does. So basically, this particulate size is mentioned on each and every packet, less than 500 microns. Many a times it is 500 to 1040 microns, and many a times it is even larger than 1040 microns. So this particulate size is actually dependent on a very simple philosophy. You are placing bone graft around the implant. You want that bone graft to be replaced later on by natural bone. You don't want that bone graft to remain as a permanent second implant. No, you want bone growth to occur into the particles of the bone graft. And for bone growth to occur into the particles of the bone graft, the interparticulate distance after condensation has to be 100 microns. And you'll be achieving this interparticulate distance of 100 microns only if your particulate size is between 250 to 750 microns, meaning between 500 to 1000 is fine. This 100 microns is actually determined by the diameter of an osteon. You want osteonal bone growth to occur into the particulate bone graft, and you want this bone graft later on to be replaced by natural bone. So just remember this thing, okay? This should be the particulate size. Now, if you were to use too large a particulate size, let's say 2000 microns as such, okay, what will happen is this bone graft particle, the interparticular distance would be huge. It won't be sufficient to promote osteonal bone growth. So bone growth, instead of being promoted, would be hampered. Second thing is, if it is too small, it would be getting resorbed, the bone graft particles, at a very fast rate, even before bone growth has actually occurred. So always remember the bone graft particle size. Now, classification of bone grafts, all of us are aware. I won't be going into the details. So in your clinic, you'll be getting few fussy patients at times, especially foreigner patients, I'm sorry to say. So they would be telling, no doc, I don't want bone graft of any other person in my mouth, that is allograft. I don't want any animal's bone graft to be put in my mouth, that is xenograft. I don't want any artificial material to be put in my mouth, that is alloplast. Put my bone only, even if you have to go in for a second surgical site. So the surgical site which I generally prefer from a accessibility point of view is the symphysis area. So incision I normally give beyond the mucogingival junction. Now, ideally speaking, I always recommend that whenever you are doing autogenous bone grafting from implants or otherwise also point of view, get a CBCT done. The ideal area is in the area of central and lateral incisor because the roots are not long. Canine root is pretty long. So with the CBCT, you will get to know the exact length of the roots. You have to be at least 5 millimeter beyond the roots, and then you can start procuring your autogenous graft. For procurement of the autogenous graft, you need to buy an instrument known as bone trephine. So this is the 5 millimeter bone trephine which I use of Amaron. This is for 5500. You use it between 100 to 200 RPM. It shouldn't be too fast. And once you'll be doing the drilling, what will happen is the moment you have gone through cortical bone and you have reached the cancellous portion of the bone, a dip would be there. You'll be feeling as if your instrument is slightly dipping, very slight. This is when you have gone into the cortical bone. So this ring would be there. Now you need to remove this ring. In order to remove this ring, you can go in for your normal Ducus bone scoop and you can remove it entirely. So once it is removed, this is how the field looks like, and then you have to suture it back. Here the sutures which I have used are PTFE sutures. Okay, PTFE sutures are non-resorbable sutures, monofilament sutures, beautiful sutures to use. Tissue resistance is the least, but two main problems are there. First is cost. Second is they're very biocompatible. Many a times they tend to get embedded. Removing them becomes an issue. Although from a photographic point of view, the color contrast is very good and no this thing is there, no plaque accumulation, etc. is there. Now, once you have removed the bone ring, this is the second instrument you need to buy. This is the second instrument. I'll just have a look. So, what about the remaining defect? The remaining defect that do we need to put a no, not at all. We don't need to put a graft after removal. Leave it open. I can leave it open. Okay. We don't need to put a graft in that because whatever defect we say, three-wall defect, whichever is a circumscribed defect, complete healing will occur. Are you getting a point? Never ever, from my side, is my point of view, put bone graft after procurement of the symphysis bone graft because then again, see, consider it from a patient point of view. Patient was telling you not to use allograft, not to use xenograft, not to use alloplast. So which bone graft ultimately you'll be putting in any case? But my point of view is it is a completely circumscribed defect. Complete healing occurs. Only slight edema occurs in the first couple of days as such. How many days of placing an implant should be? How many days of placing bone grafts? No. This you are talking with regard to Manisha. This you are talking with regard to socket preservation. Here we are talking about bone grafting, which is done simultaneous to implant placement. Okay, I am not covering up socket preservation because I don't have time for that. Socket preservation basically meant you extracted a tooth and you placed a bone graft. Now you have to wait minimum 6 months before placement of an implant. Here what we are doing is we are placing an implant and we are simultaneously doing the bone grafting. Are you getting a point? So because of that simultaneous bone grafting, naturally waiting period would be more. Instead of 3 months, minimum 4 to 5 months you have to wait. Then only you can load the implant. Are you getting my point? Okay. So how many days? This is okay. Fine. So this is the second instrument that you need to buy. This is the second instrument. This is known as bone mill or bone crusher. This is 4,500. Again, our use of Amaron. And once you have done that thing, I'll reduce this chat a little bit. Once I have crushed it properly, this is how the bone graft particles are there. You can mix it with the patient's own blood. It is ready for bone grafting. Okay. Now the second bone graft, coming to your question, which is better, FDBA or DFDBA? See, these are the two bone grafts I've been using for the last 18 years now, right from my first year of PG, 2002. So I'm lucky to have very good students who have been practicing in Bombay, and from them I have been able to procure, because this bone graft is not supplied commercially. You need to get it in person from Tata Memorial Hospital only. So both FDBA and DFDBA are good. DFDBA is osteoinductive. It induces bone formation because of BMPs. Let's not go into the details. FDBA is only osteoconductive. But clinically, the results are good of FDBA also. I personally prefer FDBA. Second advantage of FDBA is cost. It is half the cost of DFDBA. So out of the two, in case you are using anyone, that is fine enough. It is using an allograft is anytime better around an implant compared to a xenograft or an alloplast. Please remember this thing. Okay? So this is the first thing you are supposed to remember. We have xenograft also. Xenograft again are from animals. We have anorganic bovine bone by BioOS. BioOS again is a very strong company, very strong multinational company. So they tend to advertise their grafts a lot, even BioGuide membrane. An organic bovine bone, meaning ox bone, bovine bone we have taken and we have heated that bone. So by heating, what has happened is the organic skeleton has evaporated, the organic component has evaporated, only the hydroxyapatite or the inorganic skeleton is remaining. Anorganic means without the organic component. That is the fun thing. Now the problem with BioOS many times, which I have faced personally, is ox bone is very strong bone, so it doesn't get resolved that easily. So ultimately what happens is basically that over a period of time, it tends to remain there. That is one problem which I have faced with BioOS. Otherwise a good bone graft. Okay. And otherwise we can use BioCoral, which is coralline calcium carbonate. The bone grafts which we need to be very, very careful about are alloplasts. Alloplasts are basically synthetic bone grafts. We have manufactured them in the laboratory. The results which I have got with Perioglass, I'm sorry, which comes in the bioglass, around an implant aren't very promising. I'll tell you very frankly. The category of the bone graft which you need to be most careful about, the uh, just one second. The category of the bone graft which you need to be most careful about are bioceramics. So bioceramic basically means that in the laboratory, they have mixed two main components which form bone, calcium and phosphate. And ultimately by mixing, what they have done is, just one second, I think it is showing my RAM is getting full. Okay. What they have done is they have gotten a calcium phosphate product which has calcium phosphate ratio equal or almost equal to that of bone. Now the problem with using this category of bone grafts is, even though they might have mixed calcium phosphate properly, the resorption depends on the sintering temperature, the temperature at which that thing was synthesized. Are you getting a point? So ultimately the resorption is very, very poor of few of the bone grafts in this category, meaning you will be placing it 6 months later or 5 months later, you'll be trying to do the second stage surgery. You'll be raising a flap, and the entire bone graft, just like particles, will be coming out just like that. Okay, so this is one thing which be very careful. Nova bone is a good bone graft, but then again, given a choice, go in for allograft rather than xenograft or alloplast. Okay, is it fine? Bone grafting instruments I had already covered. You need a bone graft carrier syringe. Okay, membrane again. So the problem with membrane is here stiffness is not required. You just need that membrane from a bone graft retention point of view. Problem is the patient won't be ready to pay straight away for the membrane. Patient is saying, doctor, you are charging so much for the CBCT first, then implant, then bone graft. Concept of bone graft is comparatively easier to explain to the patient. membrane concept is even more difficult. Are you getting my point? So many a times what happens is membrane part becomes easy. Go in for economical membranes, periocol, colloidal. Periocol is good. Collagen membranes are available in the range of around 1200 rupees. This you can go in. For example, this particular case, this lady basically, she wasn't a very old lady, 51-year-old. Just one case I'll share. Okay. So she came, all her teeth were mobile. She was having pain in all the teeth. She basically wanted replacement of all the teeth. So basically, what I told her was that minimum 12 implants would be required, six in the lower, six in the upper. And ultimately, I don't, whenever doing full mouth rehabilitation, I try to go in for partial prosthesis, meaning segmental prosthesis, 3 to 3, 4 to 6, 4 to 6. So ultimately, what happened was six implants I placed in the lower. I don't have photographs of the lower clinical procedure, and six implants I placed in the maxilla. So, would you like to see the clinical procedure, or should I move on in the chats? Uh, should I show the case of the clinical procedure? Uh, Chat, can you hear me, Dr. Sham? Okay, so you wish to see. Okay, fine. So I'll just show you, because ultimately, see, this is one thing which I always recommend, always and always recommend. This is something known as mobile dental photography. Always and always document your cases. Always and always document your cases, because ultimately, after a period of time, after a couple of years, you should have at least a handful of cases which you should be able to show. So ultimately, what happened was, this is my clinic case in Silva. I started with the first quadrant. All the teeth were extracted, and maxilla, it is a very bad shape. Maxilla, trust me, maxillary bone, many a times, especially in cases, this was, she was a diabetic also. That time diabetes was controlled, and lot of periodontitis also was there. So ultimately, even though the teeth were moving, after extraction hardly any bone was there. So the moment you place an implant only, in this case, it is bound to fail. You are supposed to do GBR in each and every case, meaning after placement of the implant. In order to retain the bone graft, I placed periocol membrane. And then what I did was, I packed it up with the bone graft. And then subsequently, the membrane is covered over the bone graft from a retention point of view. And so, because of the buccal, bone was also gone. And most important thing is primary closure over the site. Ultimately, what she wanted was, at the same sitting, almost 2 hours or over, she wanted of the second quadrant also. Second quadrant teeth I extracted completely. And the same thing, same procedure I did, implant placement, GBR, etc. And this thing was done. So basically, what I mean to say is, especially with your full mouth cases, do not begin your full mouth cases unless and until you have a good bone graft, good membrane, and surgical armamentarium ready. I'll just flip through the case. Ultimately, lower, a lot of resorption was there. Her diabetes was uncontrolled because of the diet, etc. Lower second stage surgery was done. So after second stage surgery, upper implants I could almost see. So I exposed them with the electrosurgery only rather than giving an incision. And all the implants in the maxilla had to be placed at an angle. So this is one thing which you have to remember. Always and always remember, in the maxilla, try to place an implant as far as possible, maybe, uh, just one second. Uh, yeah, I'm sorry for this thing. Always and always, what you are trying to do is place it in an angle, 15 to 20-degree angle, so that you are able to engage. You are able to engage basically the dense palatal bone. That is a must. Okay. So ultimately, impression stage, so many implants have been placed. Not all implants can be parallel as such. Okay. So ultimately, what is required is open tray impression technique. So open tray impression technique was required. Then based on that open tray, these are open tray transfer copings. Ultimately, customized tray, opened it up, impression was taken. All the transfer copings, and you see they are jetting out through the impression tray. Impression, pickup impression of the transfer copings were removed. Maxilla also open tray impression technique was taken. Tray had to be completely reduced. Sorry for this mess. And ultimately, the impression was picked up. And once the impression was picked up, jaw relations were taken. And went in for cement retained prosthesis this time. Cement retained was comparatively easier in this case to deliver rather than screw retained. So all the abutments were placed. This was the try-in stage. Can you see a lot of resorption had occurred? Maxilla also, the prosthesis basically was divided. Segmental prosthesis was delivered, and ultimately resorption was there. And it has been couple of years now. and I've been following up the case, but on the whole, stable case. So what I mean to say is, again, the point of this discussion, guided bone regeneration, was bone graft membrane will be part and parcel of your implant practice for the remainder part of your life. Are you getting it? This you cannot let go. The second type which you are supposed to remember is gingival biotype and soft tissue augmentation. So is it clear with regard to here? And did you follow something at least with regard to guided bone regeneration? My connection breaking in between and all. So at least some things were clear, few things as such with regard to this thing. Okay. So fine, few of you have gathered. Thanks a lot. Okay. So gingival biotype. Gingival biotype basically is a term which was given much earlier by two periodontists only, Siebert and Linte in 1989. And this term basically was used to describe different architecture, meaning in your patient in whom you are planning to place an implant, you need to be aware. You need to, I'll just have a look at the chat. Okay. Okay, yes, sir. Fine. You need to be aware basically of the thickness of the gingival tissues. Are you getting a point? So we have two types of thickness. Either it can be thin or it can be thick type. The area in which the tooth is missing, forget about it. In case immediate implantation is there, you'll have to check how the thickness is. But basically, this is how you demarcate. In the case of thin biotype, it would be highly scalloped, and once you are putting your instrument inside, you will be able to make out the shadow of the instrument coming outside. On the other hand, with regard to thick biotype, instead of highly scalloped, it would be comparatively flatter and thicker. So if you were to say the thickness up to 1.5 or less than 1.5 millimeter is thin biotype, more than 2 millimeter is thicker biotype. That is one thing which you are supposed to remember. And it has been seen that the main reason why we study this biotype with regard to implant patients is implant patients generally have very high expectations. Are you getting a point? So basically what you have to remember is the amount of recession would be 3 times more almost in a thin biotype as compared to a thick biotype. So the moment recession occurs, the patient will start telling you, doc, I have food lodgement in this tooth. Maybe in the anterior region, the patient will start telling you, doc, my goodness, it is not looking aesthetically very good, or I can see my implant shadow as such. Are you getting a point? So basically what happens is, this is something which you are supposed to remember. Thin scallop type, you need to be very, very careful with regard to handling of the tissues. Are you getting it? Make sure no cuts are there, no trauma is there. Handling of the tissues has to be more gentle. Plus, with regard to implant placement, always remember, especially in the aesthetic zone, maxilla especially, if your patient has a thin biotype, always place the implant more palatally, slightly more palatally, so that even if thickness gets reduced, at least the implant shadow won't be visible, and take it more apically, take it more deeper, that is towards the safer side, because the gingival thickness is less to begin with. Are you getting a point? So always and always no problems with regard to thick dimensions. Thin dimensions are an issue, and always remember, soft tissue is supposed to be the shield of bone. Yeah, Dr. Sham. Soft tissues are supposed to be the shield of bone, meaning in thin biotype patients, whenever you are, Dr. Sham, yeah, you are saying something? Okay.
No, sir. Sorry.
Okay. No, not an issue, not an issue. Am I audible now, Dr. Sham? I
Yes,
heard your
sir.
voice after.
I
I
was
heard any
checking
voice.
in FB Live whether it is clear
Okay,
or not.
okay,
That's why
okay,
the
okay.
noise came.
I
Sorry.
heard some voice after 1.5 hours. I felt very good actually, so I felt I'll chat with you for a while. Not an issue. Okay, generally in my webinars, I tend to encourage that student interaction and seeing the students at least. Not an issue, not an issue. है ना? Okay,
Okay.
I'll continue. Okay, so the thing which I want to emphasize is that firstly, recession will be more, and since soft tissues are supposed to be the shield of bone, ultimately bone resorption will be more in the case of a thin biotype patient as compared to a thick biotype patient. So always and always remember, thicker biotype means ease of life for you as an implantologist. Firstly, at the time of surgery, what will happen is manipulating of the tissues would be easier, taking impressions would be easier, trauma won't be there, and later on, ultimately in the long run, hardly any recession will be there. So just remember this thing. Otherwise, you will end up cases like this. So this particular patient was referred to us by the Department of Prosthetics. At the second stage surgery, what happened was this much amount of necrosis was occurring, meaning basically surgery was performed, so thin biotype was there, it somehow tolerated the first stage surgery. Second stage surgery, lot of necrosis was there. So ultimately, once I remove the gingival former and just remove the necrotic tissue, hardly any tissue was there to be seen, tissue thickness. Now you cannot deliver a crown in this case. If you were to deliver crown, initially the patient will be telling you, Doc, I see a depression here. Aesthetically, this tooth is seen jutting out. And later on, what will happen is resorption will be occurring. So what you need to do is you need to do connective tissue bone grafting in such cases. So the procedure in short, I'll just show you. The first part of the procedure is basically you end up creating a pouch, a subepithelial pouch in that area. This is a 15 number blade. Blade you are not able to see because the entire blade is inside. You create a subepithelial pouch. Now, once you have created the pouch, you tend to take your connective tissue from the palatal area. Now, in the palatal area, you need to take care of the greater palatine artery. You cannot go too medially, otherwise, you will end up injuring the greater palatine artery. And what you are supposed to do is you are supposed to take it in the premolar area. Generally, the tissue thickness is more in the premolar area. So, with regard to connective tissue graft, those of you who are periodontists already, we give a vertical incision deep till the depth of the bone, till your blade hits the bone. We give two horizontal incisions superficially, only 0.5 millimeter deep, 0.5 to 1 maximum, till the thickness of the epithelium, only till the bevel of the blade. Then what we do is we raise the flap. So now the epithelium has been reflected, and can you see the connective tissue here? Now I need to remove this connective tissue. So this incision was already deep. With my blade, I deepen up these two incisions till the bone. I put my periosteal elevator here and I tend to start removing this connective tissue. Once I have removed this connective tissue, this is how a huge connective tissue looks like in case we have removed it entirely. Lot of trimming will be required. Okay. Then what happens is this is how the palatal side looks like. This is exposed bone. You cannot leave it open. You tend to suture it properly. Suturing has to be done, otherwise lot of bleeding will be there. And once suturing has been done, the next thing which you are supposed to do is trim the tissue properly. Not all connective tissue will be going inside ultimately, but it is anytime better to get a bigger connective tissue and trim it more rather than getting a smaller one. So bigger can be trimmed, smaller cannot be made large. So always get a bigger one. With one suture, this is a direct loop suture, you tend to push the connective tissue inside. Chat, something is there. Okay, thank you. Thank you. So with one suture, you tend to pull the connective tissue inside, meaning you engage the epithelium, that pouch which you had created, you engage the epithelium, you take it out, you engage the connective tissue and you take it back into the pouch, the suture, and you tie a knot here. So what will happen is that suture will pull that connective tissue underneath this pouch which you have created. Now what you do is with another suture here in the same type, through the flap, take it out, engage the connective tissue, tie it back. You tend to stabilize the connective tissue. So this is how the connective tissue is stabilized with direct loop sutures. But the problem is this connective tissue is still exposed. So what you have to do is you have to place gingival former, and then on that gingival former, as described in Linde, you give something known as crossed sling suture. You make a sling suture around that gingival former, right? So as to pull the epithelium over the connective tissue. And this was the result hardly at 1 month stage. So are you able to appreciate the increase in thickness of tissues, soft tissues which has been achieved? Are you getting it? So soft tissues are the shield of bone. Doing connective tissue bone grafting around an implant is actually easier than doing it around natural teeth. Stabilizing a CT is actually easier. CT grafting around an implant can be done at any stage, meaning many a times it can be done at the preliminary stage itself. So if the patient is ready, you can tell the patient beforehand that this tissue thickness has to be increased, then only I can place the implant. At the implant placement stage also it can be done. Surgery would be huge, meaning implant placement also, and then subsequently this thing, connective tissue also. The third stage, which I demonstrated just now, at the second stage surgery, it can be done, right? And finally, we can wait and watch also in case you feel that the tissue thickness is marginal. It may shrink, it may not shrink. So later on, after giving of the prosthesis also it can be done, but as early as possible. As early as possible. Okay, so my voice was breaking in between. Okay. So uh, till where was it breaking? Till where was I audible? Uh, did you hear what I was telling? That connective tissue grafting, Krati, connective tissue grafting can be done at any stage. Before implant placement, at the time of implant placement. The third would be second stage surgery, and finally it could be after delivery of the prosthesis also. Is it fine? Okay. Really sorry for this connection. Since the time this red zone has come in our locality, I don't know what has happened. All of us, all the people are very busy on the internet as such. Okay, fine. So I'll just continue. So this was about little bit about soft tissue grafting. Okay. Another point or two about biologic width. So with regard to biologic width, okay, audible now. Okay, Pratik. So with regard to biologic width, all of you are aware that with regard to natural tooth also, they say minimum 2 millimeter distance has to be there between crown, that is CEJ, and the alveolar crest. So minimum 2 millimeter distance with regard to this thing has to be there. Roughly 1 millimeter junctional epithelium, 1 millimeter connective tissue. This combined is called as biologic width, meaning if you are planning to place a crown also in a tooth which is fractured, you cannot simply cut off gingiva and place crown close to the gingival alveolar crest. If you were to place it close to the alveolar crest, either persistent pain, inflammation will be there or resorption will occur. So ideally what you are supposed to do is you are supposed to reduce by flap surgery and osteotomy till the time 2 millimeter distance has come between bone and this flap as such, the crown as such, the final crown. So biologic width is very, very important even with regard to natural teeth. Okay, it becomes even more important with regard to implant. So natural tooth it is 2 millimeter. With regard to implant, it is roughly 3 millimeter. Okay, this 3 millimeter is the width which is required around implant. Around implant, bone loss occurs more. The reason for that basically is because a very crucial ligament, crucial tissue, periodontal ligament, is not there. Am I audible? Can you please reply in the chats now? Am I audible? Few of the students, in case. Okay,
Yes,
fine,
sir, you
fine.
are.
Audible. Hannah, please let me know. I'll try to wind it up first. So 3 millimeter is the distance. This 3 millimeter biologic width is the reason why we say 3 millimeter distance has to be there between the implants. Okay. So minimum 3 millimeter distance has to be there between the implants. This is actually based on biologic width. Whenever an implant is placed, it tries to form 3 millimeter of bone. It resolves 3 millimeter bone around itself to regain the biologic width. Okay, 1.5 millimeter on one side, 1.5 millimeter on one side. Hence, we say between two implants, 1.5 millimeter of this implant, 1.5 millimeter of this implant. 3 millimeter distance has to be there. This 3 millimeter distance is entirely based on the biologic width. Okay, in case you place an implant, what happens is the implant tries to make a trough-like bone loss. Okay, this sort of a trough bone loss, which you must have seen in majority of the implants that we place, that is natural. The implant is trying to regain the biologic width. In case the implant are placed together, the complete bone loss and interdental papillary loss will be there. Okay. Now, biologic width, this resorption can be reduced. Instead of flat platform implants, if we are to use implants with a scalloped platform, which are not so easily available, this bone loss will be lesser. Okay, and in case we're going for platform switching also, this bone loss will be lesser. So normally implants are flat on the top. In that, because of biologic width, invariably non-biomodified implants will be having 1.5 millimeter and 1.5 millimeter bone loss. Okay, but with regard to scalloped implants, which are not so easily available, it won't be there, and platform switching, it won't be available. So platform switching basically means the diameter of the abutment over the implant is lesser than the diameter of the implant. This is known as platform switching using a narrower diameter abutment. Okay, so I'll just check the chats once in case I'm audible or not. Okay, fine. Till now I'm audible. Fine. So this has a very advantageous thing. Platform switching is very important from a biological point of view and a technical point of view. So ultimately what happens is, because of this platform switching, ultimately that abutment and implant had few microorganisms in between. Because of that, bone loss was there. Now those microorganisms, instead of being directly in contact with the bone, they are shifted over the body of the implant as such. Are you getting a point? So because of that thing, what happens is bone loss is reduced. This is the biological reason. Abutment, whenever we place to an implant, some micro gap invariably is there in which microorganisms invariably are attached. Okay, and the second advantage is the stress. Stress basically means that when you place a crown ultimately and the patient starts using that tooth, ultimately that stress concentration is shifted towards the inside. The ultimate what you say role of this platform switching is bone loss would be lesser. And this is something which we evaluated in our dissertation under me, which was done a couple of years back. Platform switched abutments versus normal abutments. So in this with CBCT, we had found out, and ultimately bone loss was less. Are you getting what I'm trying to say? Implants used were the same in both. Abutments used were different, meaning even in the X-ray, before placement of a crown, you will be able to make out whether the abutment is platform matched or platform switched, that is narrower abutment. And you see, here the abutment is of the same diameter as the implant. This is platform matched abutment. Here, basically, the abutment is narrower than the diameter of the implant. This is platform switched abutment. Okay, meaning in one set of cases, we gave the normal titanium abutment. This normal abutment, wide abutment. Implants placed are the same, alpha bio SPI. In some cases, we gave the slim abutment or the platform switched abutment. Platform switched abutment are narrow. The problem with platform switched is with regard to single tooth processes, especially with regard to cement retained, is this has a flattened surface. This has anti-rotational feature. This flattened surface is not possible in a slim abutment. And slim abutments also have a different type in which a base collar is there so that the crown doesn't slip gingivally. But did you follow? What do we mean by platform switching? Platform switching basically means implant placed are the same. But suppose this implant is of 4 millimeter diameter, you are placing the abutment also which is of 4 millimeter. Platform switching means that the implant is of 4 millimeter and you are placing an abutment which, let's say, is of 3.75 or 3.5 millimeter. Are you getting what I'm trying to say? Platform switching helps in reduction of the bone loss, but platform switching involves a lot of technical problems from a prosthetic point of view. I'll just have a look at the chat. I hope my okay. So few of you are getting. Thank you. So I'll just okay. This is how your state would be, right? In the beginning we had around 75, 78. Now everybody is running off because maybe because I'm not up to the mark and maybe because the connection also. So just hold on. I'll just try to wind it up. Just 2 or 3 more points from my point of view I'll cover up. So next thing is biomodification of implants. Now, biomodification of implants basically means that right now in the beginning I told initially we used to have additive surfaces. Now we have subtracted surfaces. Subtractive surfaces basically means all implants are sandblasted and acid etched. But suppose we are able to, something has come in the chat. Okay, thank you. Suppose we are able to modify the implant surface biologically to enhance bone formation. That is known as biomodification of implant. Are you getting my point? Meaning, under normal circumstances, it has been seen that initially, these were the pioneer studies, Edel and Elbrechtsen et al. What they realized was that some amount of bone loss is there, which is maximum in the first year. One person said it was 1.5, other person said it was as much as 2 millimeter. And then later on, it tends to reduce subsequent years. But initial years, it is the maximum because the implant tries to regain the biologic width also. So studies were done that can we enhance this implant surface and make it biologically active. So we have a category of implants which are many times calcium phosphate coated. We have Toreg OS, Noble Active, etc. So they have a surface coating which actually promotes bone formation. These implants are more expensive. Are you getting my point? But the point is, I hope my voice is not. what was the implant connection? Okay, implant connection in that study was internal hex only. Okay, both with regard to slim abutments, that is platform switched, as well as with regard to the normal, that is platform matched, it was internal hex. Okay, internal hex only. Morse taper also we used, but in that case we had used internal hex. That's fine, Fatima. Okay, so what can we do? What can we do basically to decrease this bone loss? Can we do some chair side procedure? Can we somehow enhance the potential of the implant surface so that bone formation is better? If bone formation is not there, let's say bone loss is lesser. That is where platelet concentrates come into the picture. So just have a look. Let me know whenever my voice is breaking. Okay. So basically what happens is during my PG time, we used to use PRP. Nowadays, everywhere PRF is being used. So platelet rich fibrin is the thing which we use easily as compared to PRP because no anticoagulant, comparatively easier technical process, etc. So with regard to PRF also, I would advise in between we have been trying and once or twice we were able to get, in case instead of normal silica tubes, you were to use titanium test tubes. The PRF thus obtained is known as TPRF or titanium PRF. So TPRF, it has been shown in scanning microscopic studies. The structure is much denser and growth factors are supposed to be more in TPRF. So normal PRF is known as leukocyte PRF. The centrifugation cycle is the same for both, 2700 RPM for 12 minutes. But in case you can buy and get titanium test tube once and for all, the PRF potential would be better. Regenerative potential of the PRF would be better. So this is one PRF which you can use. Second PRF which you can use is IPRF or injectable PRF, also known as sticky bone. This is basically 700 ppm at 3 to 4 minutes, meaning instead of the blood clot, what we end up getting basically is a thin, dense liquid sort of a thing. So because of that thin, dense liquid sort of a thing, basically what happens ultimately is that in this liquid, if you were to put particulate bone graft, you will be able to pick up that bone graft like a membrane. The problem with particulate bone grafts basically is that ultimately particulate bone grafts retention is an issue. So if you were to mix it up with IPRF, retention of the bone grafts won't be an issue at all. So this is one thing which you remember. So this was the first study which was done. I was the co-guide, implant bioactivated platelet rich fibrin. So in this what we did was we used the original Chokran box. Chokran was the person who gave PRF. So he has given an indigenous Chokran box also he has designed. 7,000 rupees is the cost, in which we can condense the PRF which we have obtained in a test tube. So it becomes like a membrane sort of a thing. It becomes a thin membrane. Now in this study, the main problem which we faced was once we had coated the implant surface with this PRF membrane, ultimately the osteotomy was supposed to be narrower than the diameter of the implant. So what happened was once we were trying to squeeze the implant into the osteotomy site, ultimately what happened was half of the PRF was getting squeezed out only. So in the next step of research, what we did was went a step further. Instead of taking PRF membrane, what you can do is use PRF releasate, meaning you take PRF, you squeeze the membrane. That membrane you can utilize later on for soft tissue healing, meaning once you have placed the implant, you can place the membrane over it and then suture the flap over it top. The healing will be better. But once you squeeze it, this liquid release it, which will be going into the down container, that actually contains majority of the growth factors. That release it basically can be sprayed onto the implant, and ultimately what we found in the study was that at the end of 1 year, the amount of crestal bone loss was lesser as compared to the same implants which are placed without spraying of PRF release it. So this was one thing. But then again, my favorite is bisphosphonate, meaning many a times what happens is patient is not ready for another prick. Many a times patient says that the centrifuge has to be there. Okay, so basically bisphosphonate, as you all know, is an anti-resorptive drug. Now, this anti-resorptive drug, especially alendronate, has been used widely in the treatment of bone disorders. This is a very, very powerful drug. Few of our parents might be taking it. The dose is hardly once in a week, many times once in 2 weeks, etc. So, the first thing when anybody says bisphosphonate, This is the sentence you'll be hearing. Bisphosphonates. Aren't implants contraindicated in patients who are on bisphosphonates? Definitely they are contraindicated because these are patients with underlying bone disorders who are taking bisphosphonate basically for treatment of that underlying bone disorders, osteoporosis, Paget's disease, etc. Are you getting a point? Bisphosphonate as such has been implicated that if surgery is done in these patients, it results in bronch, bisphosphonate related osteonecrosis of the jaw, although the percentage is very less. So never ever get confused. Bisphosphonate patients who are taking bisphosphonates, they are taking those medicines basically because of an underlying bone disease. So in a way, placement of implants is not contraindicated in patients with bisphosphonate therapy. In a way, a better way of saying would be they are contraindicated in those patients who have these underlying bone disorders. They should be placed with caution. Are you getting a point? Here, what we did was we basically found out that alendronate has already been shown to cause less bone resorption. Rather, earlier on in a study under me, this was 10 years back, we had modified one side plain bone graft and one side bone graft enhanced with bisphosphonate, that is alendronate. The bone formation was better in the bisphosphonate enhanced bone graft as compared to the plain bone graft. So this was one thing which was the basis of the study. So this time what we did was we decided we'll be modifying the implant surface with bisphosphonate. So basically we used alendronate tablet osteophos 35 milligram we dissolved in 2 ml of saline. And then what we did was we coated the implant. We dipped the implant immediately. It doesn't get absorbed or anything, dipping. And we immediately applied the remaining solution into the osteotomy site. Okay. This agent has to be very, very carefully applied. Wherever it spills over, what happens is lot of ulceration is caused. Okay. And then finally, at the end of 1 year, the amount of bone loss was less in the bisphosphonate treated implant group as compared to the group in which implants were not coated with bisphosphonate. So this is again a chair side thing which you can keep. You don't feel like taking out, you have trouble finding the vein from a blood aspiration point of view for platelet concentrates, etc. Bisphosphonate can be used. So again, this is one thing which can be used. Okay. So last point, is it fine till now? You want me to finish off the last point also, or the torture has been quite a bit for all of you? Is it fine? Like, am I audible? Somebody in the chat, am I audible to anybody? Okay, one chat came. Okay, it's fine, sir. Okay, fine, fine. Thanks a lot. Okay, so like we'll be finishing it off fast now, another 10 minutes maximum. Okay, I hope my voice didn't break much in between. So with regard to implant maintenance, okay, so implant maintenance basically means what instructions are you planning to give your implant patient once you have delivered your prosthesis. These are patients who will be with you for a lifetime. So there are two main instructions which you should always remember to give to implant patients immediately after you have placed your implant prosthesis. The first thing is, especially with regard to the replacement of multi-rooted teeth in the posterior areas. You have to tell the patient with the help of diagrams, maybe on your iPad, laptop, etc., that you had a multi-rooted tooth with ample roots present. Based on those roots, your gingiva was like this scalloped gingiva. Now that thing has been removed, and that multi-rooted teeth has been replaced by a single pillar-like implant in the center. So because of that pillar, now there are spaces present on this side and this side of the tooth which I have placed. It is almost a crime to send a patient without prescribing a proxa brush, an interproximal toothbrush, especially after delivering a prosthesis for multi-rooted teeth. This is the first thing. The second thing you are supposed to tell your patient is show the patient this diagram. This is a natural tooth, this is bone, and we have a very thin but very powerful tissue known as periodontal ligament in between. So periodontal ligament has something known as proprioceptors. So proprioceptors basically means pressure sensitive receptors are there. The moment I am eating something and something hard comes in between, my mouth tends to open all of a sudden. I was eating a fruit and a seed came. The pressure sensitive receptors of my periodontal ligament would be telling me straight away that open up your mouth, otherwise it will cause trauma. The same thing is missing with regard to, same thing is missing. Bisphosphonate tablets can be crushed, Dr. Sharath. It can be crushed completely and it again dissolves in normal saline. Okay. I mean, the solution also doesn't have to be a complete solution as such. Even if it remains suspended for a certain period of time, that period of time is sufficient for you to deliver the tablet. The solution is basically a method of delivering. It has to be crushed. Excellent. It has to be crushed, otherwise it doesn't dissolve that easily. Okay. This was one question. Okay. So here basically what happens is between implant and bone, no PDL is there. Okay. Direct osseointegration is there. What does that mean? The patient is eating something and something hard comes in between. The patient won't be getting to know. What will happen is the patient will apply excessive pressure and this implant, which is titanium grade 5, will get compressed lesser. This bone will get compressed more because of the pressure, and ultimately this osseointegration will break. Something has come in the chat. Okay. So basically, this thing will break. So the first instruction, the second instruction, sorry, you are supposed to give to your patient is never, you can eat with your implant tooth, never ever test your implant. Meaning, don't try to see how much harder can I bite because you won't realize once you have crossed the threshold of pressure which can be taken by the implant prosthesis. Okay. So just remember this thing always and always recall your patient for examination, check for plaque. Okay. PDL is a very powerful tissue. Are you getting a point? The entire GTR modality in perio, entire orthodontic specialty is based on periodontal ligament. PDL is absent in implant, means regenerative potential around an implant is lesser as compared to a normal tooth. So always and always remember this thing. Check for plaque again and again. Okay, always and always evaluate the peri implant tissues for color, contour, consistency, etc. Any redness which is there, always and always initiate plaque control measures. Okay, bleeding and suppuration has to be checked. With regard to probing depths, always remember. Do you remember in perio we were taught 2 to 3 millimeter is sulcus, beyond 3 millimeter is pocket. You getting a point? So 2 to 3 millimeter you used to call as normal sulcus. With regard to implants, always remember, with regard to probing depths, till 5 millimeter it is normal. Okay? The probing depths around an implant are always more as compared to a natural tooth. So not to worry till 5 millimeter. This is one thing which you have to remember. Always and always use a plastic instrument. This is something which I bought many years back, around a decade back. This is an instrument which doesn't go anywhere. The handle is common. It can be used for another instrument, but always and always use a plastic instrument in relation to the surface of an implant, never a steel instrument. Stainless steel is much more harder than titanium. It will abrade titanium. It will cause brushes. It will cause abrasion of the titanium, scratches, etc. Never ever use a metal instrument. Always use a plastic probe. It is easy to buy. Okay, and always and always I said go in for screw retain prosthesis. Screw retain prosthesis basically means, can you see? This was the titanium abutment. This we had sent to the lab. From this lab, once we get a cast back, what will happen is the prosthesis will be on the cast. You have to remove the crown, the abutment you have to unscrew, and then you have to screw that abutment onto the implant. Then what you are supposed to do is in this hole place some cotton or wax and then cement your crown on top of that abutment. This is cement retain. Screw retain basically means that during the casting process itself, this plastic abutment got melted. Now it is part and parcel of the crown. The crown is on top, which has an extension here. This is known as screw retain. Screw retain basically means we'll be taking it out of the cast and we'll be directly screwing it onto the implant. There is no need of cement. This, of course, here we'll be putting a cotton and we'll be filling it up with this thing. I have more photographs in my iPad actually, but that's not connected right now. But on the whole, just remember, here this plastic abutment, you don't have to cement. You don't even get to see this abutment at all. This abutment gets melted and now this abutment is part of the crown as such. No separate abutment remains once you get it back from the lab. Here what happens is you give this abutment along with your impressions to the lab fellow. In the lab, the lab fellow pours the impressions, puts them on an articulator, puts the abutment here, does something known as milling of the abutment. meaning he does crown cutting, let's say, just like we do tooth cutting before giving a PFM crown, and then over that he fabricates a crown. Are you getting what I'm trying to say? One query was there earlier. Maybe that person has already gone, so not an issue. Now, in which that person had asked about screw retain. So this gets melted, this remains. Is it fine with all of you? So peri-implantitis, I don't have time right now, but with regard to peri-implantitis, always and always remember one thing. We try to assess between ailing, failing, and failed implants. With regard to normal teeth, we always say gingivitis precedes periodontitis. The same might not always be true with regard to implants as such. So we have three varieties. Ailing implants, meaning a patient came to you, everything was looking normal, but the patient was telling maybe slight pain or discomfort is there. You took a radiograph, and in that radiograph, you saw some sign of bone loss has started around the implant. Now, you take a look again at the patient's mouth. You see no plaque, no calculus is there. So, most probably some prosthetic factor is there. Maybe the crown is too wide, maybe some occlusal interference is there. Look for those factors. Those are ailing implants. Failing implants means you take a radiograph, bone loss is occurring, and at the same time, soft tissue inflammation is there. That means plaque and calculus also has come in. So again, you need to initiate some form of interventional therapy. Okay? Failed implants. Just remember one thing: mobility is not a late sign. With regard to peri-implantitis, mobility is the last sign with regard to peri-implantitis. If it is shaking, time to take out the implant. But the point remains the same. Initially, when I started placing implants and the patient used to ring up, Doc, you had placed the crown is shaking. My palpitations used to increase. But ultimately, that used to be abutment screw loosening. So, whenever a patient tells that my tooth is shaking, take a radiograph and then try to remove the crown first. It might be only the abutment screw which is loose rather than the implant shaking. Okay. Now, suppose the patient has developed a pathology on the implant. So, peri-implantitis part I had removed that time. Just remember one thing: always and always use plastic curettes rather than metallic curettes. So with regard to implant placement, remember I had told you 4R, 4L, universal Gracie curette, right? Universal Columbia curette. Here we have universal Columbia plastic curette. Same handle, different tips. So you can buy one handle of Euphridian, four tips, two for probing, two for curettage. So plastic curettage actually takes time. Be patient. Okay. But the point is always and always use plastic. Never ever we have to use stainless steel with regard to implants as such. So finally, the slide which brings a smile to majority of the delegates, be it in a normal face-to-face conference or be it in a webinar. Here I'm not able to see the smile as such, but you people are able to hear me, I hope. Last 2 hours I've been hearing my sound only. Okay. Otherwise, I love hearing between one or two yes sir, no sir, or whatever. Okay. So somebody has given something. Sir, Cybograft, your opinion. Sir, any key points to remember when placing non-parallel implant? Yes, sir, please take one webinar on peri-implant. Wait, later on. Okay, and this is not the last slide. Let me wind up first. Okay, so with regard to this conclusion, I would like to say that this time is over. We need to stop finding faults with the implants placed by everyone else other than ourselves. Okay, that is very, very wrong as such. Isn't it rightly said, a mistake which makes you humble is much more better than an achievement which makes you arrogant. So just remember this thing always. Okay, and the eye doesn't see what the mind doesn't know. Okay, so theory has to be there, basics have to be there with regard to this thing, then only you'll be understanding anything. I've just been able to cover up the tip of the iceberg. I've been speaking for 2 hours continuously now, not continuously, 5 hours, little bit that connection had gone in between. So again, um, this was the thing which I am expecting. I'm not sure. This might be the thing. Half of you might have switched off and ran off. As such. I'm really, really thankful to IDA Ernad branch. Mainly, I was dealing with Dr. Sham only, but everybody as such. Thanks a lot. Thanks a lot. I don't know how you invited me, but thanks a lot for the honor. I'll always love sharing things as such. Few things I've been able to share, and thank you all for a very, very, um, what do you say, patient audience. I wasn't able to this thing. Mm. Now, what all doubts do we have? Cybograph, I don't have a very good opinion about Cybograph. I'm sorry. Okay, what else do we have? Um, Dr. Sham, is it possible to see the attendees?
See the attendees, yeah, I can promote them as panelists, sir. If you
Okay,
want,
okay,
I
okay.
can promote them.
Yeah, all of them if
Eh,
possible.
no, it's not possible. I will
Because at
promote.
least,
I will promote one by one.
Acha, one by one is possible. Okay, okay, okay.
Those who are ready, they can.
Wound healing occurs through reattachment or new attachment. Okay. This is screen sharing as the window is closed. Now, please repeat once about bone particle size. Excellent. Okay. So, those of them who are asking questions, can they come online? It would be easier, or I'll answer live. Question and answer are coming.
Yes, sir. Can I read it? The questions.
Yeah. No, I am able to read. Okay. So,
Okay.
with regard to reattachment and new attachment. So, reattachment basically, Apurva, is repair. Okay. It is not regeneration. New attachment is another term for regeneration. So GBR, what we can say is new attachment is occurring. Now, new attachment isn't exactly a correct word because new attachment is a word which we retain with regard to mainly. I would say natural tooth. Natural tooth because periodontal ligament has to get attached as such. Are you getting a point? Now, here what happens is there's no attachment as such. So ultimately what happens is it is just bone formation occurring in close approximation to the implant. Are you getting a point? So instead of using reattachment would be absolutely wrong. New attachment also wouldn't entirely be correct. I would say the main thing should be regeneration around implants. Okay, is it fine, Apurva? Regeneration would be a better term. Okay, otherwise new attachment in this thing. So one question is here. Where are the rest? Okay, Shikha. Repeat once more about bone graft particle size. So particle size is a very sensitive term. Okay, particle size has to be such that ultimately it has to be enclosed and main bone, the final bone has to grow onto the particles. Okay, suppose the particle size is too small, phagocytes would be engulfing it and resorbing it at a very, very fast rate. Are you getting a point? On the other hand, on the other hand, if we are having a particle size which is too large, between the particle size, what will happen is ultimately bone growth won't be possible. So bone growth is something in which the bone graft has to act like a matrix. Matrix basically means you have seen how the rooftops are put when they are putting those concrete. Ultimately, what happens is they tend to put those wires, steel wires in between, and then they put concrete on top for putting our rooftops. Lantern, we call it. Now, suppose those wires, the steel wires, are put too close together or they are too thick, they are too wide apart, the concrete would be flowing right through those wires. Those wires have to be of a particular diameter and they have to be at a particular distance. Once you are condensing particulate bone graft, that distance maintenance is not possible. That distance is possible only if a particular particle size is there. So it has been shown that between 500 to 1000 or specifically 250 to 750, if you were to condense bone graft particle, the in between particulate size would be just sufficient for osteonal bone growth. That is 100 microns. So this is about particle size, that bone should be flowing in between the bone graft particles. This is one. Is it fine, Shikha? Opinion about cybograph. Cybograph, I don't have a very good opinion. My results have not been. Repeat about bisphosphonate. Okay, what is about shorter abutment. Okay, so bisphosphonate and okay, Shikha. So this thing bone particle size is fine. Shorter abutment. See, with regard to less interocclusal clearance, always and always going for screw retained rather than cement retained. If you were to give cement retained again and again, the prosthesis would be coming out. Okay, so always one of the major indications of screw retained basically is actually going in for smaller this thing. Are you getting it? Screw retained only. So I wouldn't advise going in for shorter abutment at all, Dr. Gajanan. My advice would be go in for only screw retain. How do you decide whether internal? No, external connections are out, Dwanit, completely out. Dwanit, okay, external connections used to be used long time back. Ultimately, Noble used to use, but lot of plaque accumulation, lot of this thing was available. External hex is completely out. Right now, we have internal connections only. Internal connections we have two mainly: internal hex and Morse taper. Internal hex is more flexible with regard to multiple teeth prosthesis. Whenever we are delivering the prosthesis, you'll be finding that internal hex is easier than Morse taper. Morse taper, it goes deeper. So abutment screw loosening is lesser, crestal bone loss is lesser with regard to Morse taper. So my recommendation would be external hex out, internal hex with regard to internal connection, internal hex in case multiple tooth prosthesis has to be delivered. In case single tooth prosthesis has to be delivered, going for Morse taper. But then again, internal hex. Okay. Bisphosphonate. Bisphosphonate is a drug which actually prevents bone resorption. It is basically used in patients with bone disorders like osteoporosis, where bone loss is occurring at a very fast rate. Are you getting a point? So, suppose you put bisphosphonate around the implant and then you place it. What will happen is the normal resorption of bone, which would have been faster during the first year of loading, that would be lesser. So the role of bisphosphonate basically is, Dr. Maria, it is basically resorption, stopping with, see, all of us know bone hemostasis, bone formation, resorption. So what it does is it stops the bone resorption phase. That is the role of bisphosphonate. Okay, he's going to answer this question live. Okay, Dr. Sham, you want to answer?
No, sir, I didn't.
Okay. Okay. So, yeah.
I,
So, initially, generally towards the end, I try to take a snap with all the this thing actually.
sir,
Uh,
actually, all are stopped their video and no one is responding.
no one is
I
fine.
promoted few of the attendees to as panelists, but still all don't know.
They don't know whether they are here or not.
Yeah,
No,
yeah.
not an issue. Not an issue, Dr. Sham. Thanks a
Okay.
lot for the honor. And it is a
Thank you
huge
so
privilege
much,
for
sir.
me to present it all the way in Kerala. It wouldn't have been possible for me otherwise, maybe normally to come, but I would love to visit your place a lot. Maybe
Sure,
next
sir.
time.
Sure.
One second there. How is platform switching better when area of the less appears like? No. Uh, Actually, platform switching is better from a microbial accumulation point of view. The distance is much lesser, Dr. Cherry. The distance is much lesser for any accumulation as such. Okay, it is in millimeters. So that millimeter distance won't be accumulating this thing. What we think is, whenever we talk about accumulation, we are talking about microbial colonization. Microbial colonization is basically from saliva. So no obvious particulate this thing. The difference in the diameter is not there to such an extent, ultimately that it would lead to a lot of plaque accumulation as such. So don't, it is not macroscopic as. Can you please explain about emergence profile? Emergence profile basically means that how this thing, the final prosthesis will appear coming out of the gingival tissues. Are you getting a point? Meaning, many a time, suppose you are giving a central incisor, you have placed an implant in a central incisor, and you have placed hardly a 3.3 millimeter diameter implant. So what will happen is, try to imagine your crown, which is like this, and then it is converging like this. So ultimately it appears as if it is like a lemon on a matchstick. Crown is that huge, and this thing is very small. Are you getting a point? So basically, what happens is this thing is not there. Uh, Emergence profile basically means the way it is emerging from the gingival tissues, it should appear compatible with the tooth it is replacing. So ultimately, with regard to especially central incisors maxilla, we need to place a wider implant so that the emergence profile is acceptable. How the crown is emerging out of the gingival tissues. Okay. Okay. Dr. Fatima, how can we maintain hygiene around implants with reduced attached gingiva? See, with reduced attached gingiva, uh, the Linde says it very correctly. It is not a necessity that bone loss or resorption will be occurring with regard to this thing. Are you getting a reduced attach gingiva? But what happens is precautions have to be there, meaning abrasive toothbrushing should not be there at all. It has to be super soft toothbrush only, but more frequent brushing has to be there. First point. Second point, always and always we say with regard to especially patients who have less width of attached gingiva, less thickness of gingiva, oral irrigators have to be used. So water pick is very expensive, but normal irrigators which are available on Amazon, they are for 2 to 3,000. Oral irrigators should be advised. So two things with regard to Dr. Fatana, it is firstly super soft toothbrush and oral irrigators. So is it fine? Okay, okay, thank you. That's it, I think.
Yes, sir, that's it. I think we don't have more questions. I invite Dr. Sanil Babu, our branch secretary, to share few
Oh,
words.
okay, Arif, please, please.
Yes. Good evening, Mayur sir.
Good evening, Dr. Sanal. How are you?
Good evening, and all other lovely participants. I'm Dr. Sanal. I teach Ernad
Yes, sir.
branch. It
Okay,
was
okay,
an
sir. Okay, sir.
interesting webinar on periodontal surgical considerations for implantology.
Arif,
We
thanks
have
a lot, sir.
provided so many things to our members like IRS, incision, flap reflection, suturing, different types of implants, prosthetic parts, bone grafting, etc., etc., etc. Your presentation was excellent, sir. First of all, I would like to thank all the participants, those who made this program a big success. On behalf of IDA Ernad branch, I really appreciate and thankful to Dr. Mayu for being our faculty. Thanks again for spending your valuable time for us. Special thanks to Dr. Balakrishnan sir, our president, Dr. Shyam and Rose, Dr. Rose for the support. And thank you all.
Thanks a lot, sir. Thanks a lot.
Thank you, thank you.
Thank you, sir.
Thank you, thank you.
Sir, it's a small a memento from our
Okay, Arif,
we
thanks a
don't-
lot, Dr. Shyam. Thanks a lot, Dr. Shyam. Thanks a lot.
Okay. Thank you, sir. We
Thank
are
you.
winding up.
Thank you.
Thank you all.
Thank you. Thank you.